Sorry about that, Professor. These things happen unexpectedly. I assume communications are restored.
So we're told, Commissioners. We understand there was a power failure that interrupted court services and transmission, and power has now been restored and the link has now been restored, so we can continue with the evidence.
Very good. Please proceed.
Thank you. Dr. Sluggett, I was asking you about the meaning of big data in the context of your description of the focus of your research, namely using big data to understand and improve medicine use in older Australians receiving community and residential aged care services.
Yes, thank you. So in the context of healthcare and the data that I work with, big data refers to the large amount of routinely collected information that occurs within as part of the process of accessing healthcare. And so it refers to the volume of data that's collected routinely, but also ways that we can pull that data together from different sources and sort of link it all together with the purpose of better understanding processes and outcomes associated with that care.
Thank you. You mentioned in your research background your current study on simplification of medications. I'll come to that towards the end of your evidence as well. Before we go into the particular content of your statement relating to some of the side effect risks associated with the use of various medicines, particularly in the older population, I want to ask you about the work of a research group known as the Registry of South Australians within the South Australian Health and Medical Research Institute. You've been collaborating with the Registry of South Australians, is that
Yes,
right?
I have for the last several months as part of my fellowship.
Thank you. I want to ask you about two preliminary reports of a project being conducted by the Registry of South Australians, which is known as ROSA, isn't it?
Correct.
I'll ask firstly about antipsychotic medicines dispensed before and after in residential aged care, the preliminary report of ROSA, which is tab 129. So, Dr. Sluggett, firstly, what's the nature of this particular project?
Thank you. So this particular project set out to look at how psychotropic medicines, so in this example, antipsychotics, the use of those medicines changes in the, 12 months before someone is admitted to residential aged care and then the 12 months afterwards.
Thank you. And if we go to page 0002, we see that there's a particular cohort of not just South Australians but Australians generally who are the subject of this study, is that right?
That's correct. So there's two main parts to the ROSA registry. There's a national historical component which has linked health data for residents, all residents who have had an aged care assessment and accessed aged care services, I believe, since 1997. So it's a very long historical amount of linked data about those residents. And then there's also a prospective component which follows residents of South Australia prospectively. So this particular analysis looked at using the historical component of the registry.
And was the focus on people who entered permanent residential aged care in a 2-year bracket between 1st July 2013 and 30th June 2015?
That's correct.
And it also looked at the year either side of that bracket? Is that
That's right. So we looked at medicines use the year either side. So that way, if somebody entered in the 1st of June 2013, we still needed to look back the 12 months earlier to look at their medicines use.
Thank you. And if we look at the data sources for the study and call out the paragraph immediately under that heading on page 2, please just explain in summary terms the data that was used.
Yes, certainly. So we linked together, the ROSA historical component links together a range of different data sources. Some of that data comes from the Australian Institute of Health and Welfare, and it tells us about what types of, so when someone had an aged care assessment, the date, the data that was collected as part of that assessment. It also tells us what aged care services they access. And so for this particular study, we were interested in what was the date that the person accessed residential aged care. It also contains information about the data collected as part of the ACFI assessment process. So we have access to all of that type of data. It collects information. We used information from the Medicare Benefits Schedule, which is claims submitted by GPs for services that they may provide under that schedule, and also from the Pharmaceutical Benefit Scheme. So we can see when medicines are dispensed under that subsidy scheme to residents.
So just pausing there, would it be fair to say that the study that is conducted under this project is resting on an inference that if a medicine is dispensed, it's probably being administered as well?
That's correct. So dispensing is close to the point of care, but it's not at the exact point of care. So we're making an assumption that if a medicine was dispensed, it was administered. We don't know when a medicine is dispensed, if it's necessarily for regular use or for when required use. So we don't know the exact duration of use from this study, but we can infer it in some analyses using the data.
We'll now go to page 5. And Dr. Sluggett, could you please just outline for the Commissioners characteristics of the cohort? It seems to have been a very large cohort.
It was, and that's because it includes all eligible Australians who access residential aged care during that 2-year period. So it is a truly national representative study because it includes everybody. And so there were more than 97,000 residents included in this study. And so what we saw was in the 3 months after somebody entered residential aged care, 21% of all residents were dispensed an antipsychotic at least once during that 3-month period.
Perhaps we should now go to the graph, which is on page 7. And if you would please explain the first perhaps the top graph, and then we'll go to the second graph, which is a separation of 2 groups within the overall cohort. Is that right?
Yes, thank you. So in the top graph, we can see on the bottom axis, that is the 3-month intervals in the 12-month period before someone enters residential aged care and the 12 months afterwards. And on the vertical axis, that represents the proportion of people who were dispensed an antipsychotic. So what we can see is 12 months before the group of people entered residential aged care, there was around just over 5% of people were dispensed an antipsychotic at least once during that 9 to 12 month pre-period. And then as we move closer to the point of entering residential aged care, there is the prevalence of use of an antipsychotic, or the proportion of people dispensed an antipsychotic, starts to increase. And so in the 3 months before somebody enters residential aged care, it's roughly around 12% of people are dispensed an antipsychotic at least once. And then in the 3 months after somebody has entered residential aged care, it's around 20 to 21%, or it's around 21% of residents. And in that year afterwards, there doesn't seem to be a large change in the proportion of people using dispensed an antipsychotic, so it stays relatively stable.
What are your reflections on that step change between 3 months before and 3 months after?
A couple of comments. So I guess these are a cohort of people that all enter residential aged care, and so when they're living in the community, we may expect that their symptoms are starting to progress, and they may need one of the goals of care may be to remain at home in the community as long as possible. And so it may be that an antipsychotic may be trialled to help to manage some of the behavioural and psychological symptoms of dementia. And then, so certainly that may explain some of the increase leading up to the time of admission. There seems to be a large jump in antipsychotic dispensing in the 3 months before and the 3 months after. And so it tells me that during that time of transition, whether it's when people are transitioning from the community to residential aged care or from community to hospital to residential aged care, there seems to be an initiation of antipsychotics, particularly during that period. I imagine that for some residents, the transition from home to residential aged care may cause stress or distress, and so that may present as more people may present with sort of behavioural symptoms of dementia during that time, particularly if they're unable to communicate verbally. And so antipsychotics may be commenced to sort of manage those symptoms. And so I guess it indicates to me as well that non-pharmacological techniques to manage the behavioural and psychological symptoms of dementia are going to be particularly important during that transition time and during those first few months of stay in a residential aged care facility.
The Commission has heard a lot of evidence in the Sydney hearing, including from Dr. Juanita Westbury, about whether the prescribing of antipsychotics for people showing behaviours associated with their living with dementia was appropriate, given the very significant risks, many of which you explain in your statement. So we'll come to those issues. I should let you explain the graph below as well, which identifies who within the cohort had a diagnosis of dementia. Is that right?
That's correct. So in this particular graph, we've taken those analyses and we've stratified by the results by whether a person had a formal diagnosis of dementia. And so in the orange line, we see people who are living with dementia, and in the grey line, we see people who did not have a formal diagnosis of dementia. And what we can see is that increase in antipsychotic use is particularly pronounced among people who have a formal diagnosis of dementia, and that is consistent with one of the indications of use for antipsychotics.
In this context, what does at least once mean? The writing of one prescription which potentially could, as we have been told, provide for the availability of the drug for up to 12 weeks. Is that right?
At least once, it means that they received one PBS supply of the medicine during that time. So it depends on what dose the medicine is prescribed at and what the frequency is, and whether if it's prescribed for regular use or occasional use. And so it's true that a medicine may be dispensed just in case if it's on a when needed basis and never used, or it may be dispensed for regular use. So we've just looked for one dispensing during a 3-month period.
Interestingly, however, that the high rates of dispensing thereafter don't peak, they remain at that level.
That's correct. That's correct. So the rate of initiation, that tells me that during that period after which somebody enters residential aged care, it may not be the same people who are on antipsychotics each quarter, but the rate of initiation must be very similar to the rate of discontinuation because it plateaus.
Thank you. Dr. Sloggett, I'll now ask you about the second preliminary report, which is tab 130, which appears to relate to different families of psychotropics.
Yes, this report mentions the use of antidepressants and also benzodiazepine medicines.
And is it otherwise essentially using the same data and the same methodologies?
Exactly, the same data, the same methodologies for exactly the same group of people who access residential aged care services.
Thank you. So shall we go to the summary on page 3, and if you could please explain that, and then we'll go to the associated graphs.
Yes. So using the same methodology, we looked at whether a person received a supply of an antidepressant in the 3 months following entry to residential aged care, and we found that 38.8% of residents received at least one antidepressant during that time period. We also found that 28.6% of residents were dispensed at least one benzodiazepine medicine during that time period.
Thank you. We'll go to page 5, which appears to be an overlay of both the benzodiazepine and antidepressant dispensing. If you could please explain that
Yes.
graph to us.
So the green line represents benzodiazepines. So benzodiazepines are medicines which are used for a range of different conditions, but some of the most common indications for use are trouble sleeping, insomnia, and also for anxiety. And so what we can see is around 15% of people are dispensed a benzodiazepine at least once every quarter in the lead up to sort of entering residential aged care. In the 3 months before entering residential aged care, we can see it slightly increases to around 17% of people. And then in the 3 months after entering residential aged care, it increases to around 25%. And then it starts to drop off a little bit, and it remains at around 20% of residents every quarter receiving a benzodiazepine at least once.
Do you have any reflections, just pausing there on that,
Hmm.
peak, although it must be said the prevalence of dispensing of benzodiazepines doesn't return to the baseline, but there is a marked peak there.
Yes.
Do you have any reflections on that, Doctor?
Yes, again, during that transition period, I suspect that people may be transitioning from community to residential aged care. It might be via hospital. This could be a stressful time for some people, and this could present as people feeling stressed, people feeling anxious, or people not being able to sleep. And so that might be one of the reasons why we're seeing an increase in the dispensing of that medicine at that point.
Thank you, and please go on and explain the antidepressants.
Yes, so
aspect of the drug.
antidepressants are used for a range of conditions, so including depression, but also things such as pain. And so there was quite a high prevalence of use 12 months before entering residential aged care. We can see that it's around 28% of individuals were dispensed an antidepressant 9 to 12 months before entering. And then we see a gradual increase in the use of antidepressants. So it's roughly around 32% in the 0 to 3 months before entering residential aged care, and it's roughly around 37% in the 3 months after. So we're seeing more of a gradual increase in the use of those medicines.
I might now ask the operator to display both page 6 and 7 at the same time, splitting the screen into two. Is it the case that these are graphs which again separate out different subgroups within the cohort?
Yes, that's correct. So in these figures, we have again stratified our findings by whether a person has a formal diagnosis of dementia or not. And what we can see is in figure 2 that the prevalence of antidepressant dispensing is very similar among people with and without dementia in the lead up to entering residential aged care and thereafter. And what we can see when looking at figure 3, when looking at the proportion of people dispensed a benzodiazepine, the use of benzodiazepines follows a similar pattern in both cohorts of people, but we're seeing a reduced prevalence of use of benzodiazepines in people living with dementia as compared to people without dementia. And that is, I think, that is a positive part of the finding, because we've also seen in the previous graph that people with dementia are much more likely to receive an antipsychotic. And so antipsychotics and benzodiazepines are both sedating medicines, and that can lead to a range of medication-related harms. And so it's possible that because people may be on an antipsychotic, there's recognition of that and less use of benzodiazepines in that particular group of people. But it is still a reasonably high prevalence of use.
Thank you very much. We can close those documents now. And we'll return to your witness statement at page 0003. In the heading under relationship between medicines use and selected resident health outcomes, you identify 5 risk factors in relation to medication use or perhaps overuse in the context of residential aged care. Is that right, Doctor?
That's correct.
And we'll go through those in succession: falls, urinary incontinence, infectious diseases and antimicrobial resistance, weight loss and diabetes management. In respect of falls, you refer to research conducted within the the Centre for Medicine Use and Safety, I take it?
Correct.
And you've also acknowledged all your collaborators in that centre whose work has provided much of the foundation for what appears in the statement, I understand.
Correct. It's very much a team effort. So I've drawn on evidence from a range of different people's research projects as part of our centre. So yes, definitely acknowledge those people.
Could you please give the Commissioners an overview of the studies conducted and what the research is saying in respect of falls risk associated with medication use within aged care?
Mm-hmm. So some of the evidence that I've presented in this section is around an ongoing cohort study that we've been conducting in residential aged care. It's involved 6 residential aged care services in South Australia. The residents included in that study were recruited in 2014, and we've been following them over time since that period. So there's 383 residents that have been involved in this particular study. And so we've done a range of different research studies involving this cohort of residents, and it's been valuable in providing clinical information and risks associated with medicines use. And so we know that there are certain medicines which can increase the risk of a person falling, and those medicines include medicines such as psychotropic medicines, which we've heard about, opioid pain reliever type medicines, and also medicines that can cause orthostatic hypotension, which is when there's a drop in the blood pressure when you're going from sitting to standing or from lying to standing. And so these are some of the high-risk medicines that can increase the risk of falls. So in this particular study, we were interested in is what is the prevalence of use of those types of medicines associated with an increased falls risk among residents? And then also, how many falls do residents have? And what we found was that of the 383 residents included in this study, 92% of residents took at least one medicine known to increase the risk of falls. And when we looked at that a little bit closer, we saw 74% of residents took at least one psychotropic medicine or an opioid medicine, and 86% took a medicine that could worsen orthostatic hypotension. Interestingly, in this cohort of residents, there was a relatively low prevalence of use of antipsychotic and sedative hypnotic medicines.
Thank you. And there seems to have been an analysis in 2 parts of that cohort and the effects of the use of those medicines that increase the risk of falls. What was the finding in relation to the first stage?
Certainly,
of the
thank you. So we followed the residents for 12 months and we looked to see how many falls they had during that time. And what we found was that the median number of falls per resident was 1. And so but there were 206 residents, so just over half of all residents who had at least 1 fall. And so on average, the average number of falls for those residents was 3 during that 12-month follow-up period. And then we also looked at hospitalisations for falls or conditions relating to falls, so fractures, so falls and fractures. And what
was that the second stage of the analysis?
This was a second part of the analysis.
Thank you.
And so what we found was that when looking at hospitalisations for falls and fractures from residential aged care services, they account for 1/4 of all hospitalisations over a 12-month period.
Thank you. Could you speak to the separate root cause analysis? And firstly, could I just ask, when you use that expression root cause analysis in a context of association of medication and falls risk, what's the methodology? How do you go about finding out a root cause?
So in other studies, we've looked at what medicines are associated with falls. In a root cause analysis, we're really trying to identify some of the underlying processes or contributing factors that are the main causes for an event. So it's really a process of identifying who the cases are. So in this case, they were people who were hospitalised for falls. and then collecting data about those people to understand more about potential causes for those falls and those hospitalisations, and then reviewing that data and finding potential contributing factors, and then generating some recommendations about how we could prevent this from happening in the future or minimise the risk of this happening in the future, and then looking at implementation of those recommendations.
So just stopping you there, the process seems to be a painstaking inquiry-based process rather than a statistical analysis, is that?
That's correct.
And then the findings, so to speak, are submitted to a panel of experts, is that right?
Exactly. So we engaged a panel of experts as part of this process. So I believe it was, might have been 10 to 12 experts as part of a multidisciplinary panel. So we included a geriatrician, a GP, aged care provider staff, a physiotherapist, pharmacists, a consumer representative and other people. And so we asked them to give us advice on what kind of data do we need to collect to start with, and then also we presented to them some of our findings and asked the clinical panel what were their recommendations moving forward about how we could reduce the falls and reduce the hospitalisations potentially.
And there were a range of strategies that came out of that expert panel, as I understand.
Correct.
Distilling them all, perhaps that's not possible, but what was the headline recommendation that you've noted in your evidence?
Yes, so I've noted that there were quite a few recommendations relating to the potential contribution of medicines to the falls and the fall-related hospitalisations, and this involved things like increased doses immediately before a person fell of falls risk medicines, and also use of when required and regular falls risk medicines at the same time, and also other factors such as there are a range of other health services that we sort of identified.
And a recommendation you highlight out of this is the need to have a falls risk status section up front so every carer can see it in the care documentation for the resident, is that right?
That's important. And also we reflected on that, you know, a community pharmacist is dispensing a medicine that could be associated with an increased risk of falls, but the community pharmacist may not have any clinical information or knowledge about that resident. And it would be nice for, you know, a community pharmacist could play a role in flagging this person is being dispensed a medicine that could increase the risk of falls. Perhaps you should consider monitoring this resident a little bit more closely in the next couple of weeks to see if, you know, they're at an increased risk of falls. But because the community pharmacist doesn't have a lot of information about the person's baseline falls risk and whether they're low risk, medium risk, high risk, it was felt that displaying that type of information more prominently on the medication chart and giving that information to all stakeholders involved in care might help to reduce some of the risks associated with falls.
Thank you. The Commission's heard evidence about the devastating impact that falls can have on the quality of life, indeed the life of a person in aged care. It can really be a crisis which leads to a far worse outcome for them for the rest of their lives, can't it? So
yes.
This is a very important measure.
Certainly.
Now, could I ask you about the second side effect or risk factor that you've identified as particularly acute in connection with the use of medications in aged care, which is urinary incontinence? This is a section of your statement beginning at page 5 and going over the next 2 pages. Firstly, you've in effect defined it for us, and then you've referred, based on administrative data from the ACFI process, to what you understand to be the prevalence of urinary incontinence?
Yes, that's correct.
Which is extremely high.
Yes, approximately 2/3 of residents experiencing at least one episode of urinary incontinence each day.
And Dr. Sluggett, you've identified every likelihood of a connection with medication in respect of at least a significant number of those people, is that right?
Yes, it seems that there is quite a lot of use of medicines which could be associated with urinary incontinence, either new incontinence or worsening existing incontinence. So data from the general Australian population suggests that 9 out of 10 older Australians could be using a medicine that's associated with urinary incontinence.
And you've given us a table on the next 2 pages of a number of common medication groups
That's right.
that have a worsening effect or an exacerbating effect or
That's
a causative
correct.
effect even
That's correct.
on
That's
urinary
correct.
incontinence.
And so there's a wide range of medicines, types of medicines that can be implicated in urinary incontinence and different types of urinary incontinence.
So without going to them all, but just for the purposes of, in effect, public education on this,
Yes.
there's ACE inhibitors. They are blood pressure lowering medicines.
Yes, that's correct.
There are other medications used to lower blood pressure, alpha-1 androgenic antagonists.
Yes.
You've referred already to antipsychotics. They also have this effect on urinary incontinence as well.
They can impact on urinary incontinence in a variety of different ways.
And you've already mentioned benzodiazepines.
Yes. So the antipsychotics and benzodiazepines, one of the mechanisms is through, it could exacerbate functional incontinence. So functional incontinence is when a person is not able to get to the toilet in time. And so if a person is taking a sedating medicine or a medicine that affects their movement or their alertness, then that could impair their ability to get to the toilet in time.
Thank you. And particularly in the context of residential aged care, we know that there's quite a significant prevalence of people living with dementia.
Yes.
We're told it's over 50%.
Yes.
And so one of the other families of medicines you've mentioned, cholinesterase inhibitors, seems particularly relevant in that respect for those people living
Correct.
with, say, Alzheimer's disease. Is that right?
Correct. If they are being treated with a cholinesterase inhibitor, there is a side effect associated with that medicine that some people may potentially experience, which is urinary incontinence.
And that presumably may have a compounding effect on some degree of cognitive impairment they already may be living with. Is that a fair
So
remark?
the cholinesterase inhibitor is used in the treatment of helping to improve memory among people living with Alzheimer's disease.
But if they have a degree of cognitive impairment, that may...
That condition itself may be impacting on your ability to recognise when you need to get to the toilet.
And you also mentioned that diuretics are used for certain cardiovascular health conditions.
Correct. So things like heart failure to get rid of the fluid that accumulates in the body.
And a couple of families of antidepressants are mentioned there, and I haven't mentioned all of the families of therapeutic substances in the table, but it's quite an extensive table.
It's quite an extensive table, and so some of these medicines are used quite commonly among residents. And so I think it's a challenge because it's, is everybody able to recognise all of these medicines and how they might contribute to urinary incontinence?
And with reference to the points that you've given us in paragraph 15, what do you suggest could ameliorate the effect of medication on urinary incontinence?
Yes, certainly. So I think pharmacists, as medicines experts, are really well placed to be able to identify potential medicines that may be contributing to someone's incontinence. And so increasing the input from pharmacists into residential aged care setting could be one mechanism to achieve this. Another mechanism could be involving pharmacists at the time that an ACAT is done, because obviously urinary incontinence is an important contributing factor that can contribute to the decision to move to residential aged care. And so looking a little bit earlier at medicines that may be impacting on urinary incontinence could also be beneficial.
Thank you. The third factor which you have identified as associated with the use of medications in the aged care context is infectious diseases and antimicrobial resistance.
Yes.
And you've identified for us that there are antimicrobial stewardship initiatives currently in progress. Is that right?
So in the hospital setting, there's dedicated antimicrobial stewardship activities. Internationally, there are dedicated antimicrobial stewardship activities in residential aged care. And so I guess as part of our research, we were looking at what are some of the factors around that. So we conducted a root cause analysis looking at hospitalisations for infection using a similar methodology that I talked about before. And I guess skipping to the recommendations, one of the recommendations of our clinical panel was around the importance of antimicrobial stewardship in residential aged care and the need to establish those systems.
So there's a gap in the aged care setting by comparison with hospitals, is there? And
I believe so, yes.
Was this study addressing the extent of that and what should be done about it?
It wasn't addressing it so much in terms of antimicrobial stewardship activities. It was more just looking at what are the contributing factors to infections and hospitalisations for infections. And some of the contributing factors were potentially suboptimal use of antimicrobials in the residential aged care setting, an inability to administer certain types of antimicrobials, and so a range of issues around quality use of antimicrobials. And so therefore it was thought if we could improve the way that those medicines were used in the residential aged care setting, then perhaps that may reduce some of the need to hospitalise people. So that was where the antimicrobial stewardship recommendation came about.
Thank you.
I'm not sure I understand that. Can you
Yes.
put it a bit more in layman's language? Are you saying that more effective prescribing could reduce the incidence of microbial problems or not? I just didn't understand.
Yes, certainly. So we know that factors such as selecting too broad a spectrum antibiotic or using antibiotics for too long or at inappropriate doses or inappropriate routes of administration can increase the risk of, contribute to antimicrobial resistance in the community.
So it's about resistance.
And so it's about improving the way that antimicrobials are used, initiating treatment at the right time, at the right dose, the right selection. And so therefore the antimicrobial stewardship type program could contribute to improved use of antimicrobials overall.
And you mentioned in paragraph 18B that there's actually a mandatory program to, in effect, encourage appropriate use of antibiotics in the US in the aged care setting?
Yes. I don't have a huge amount of detail on that program, but it is a mandatory program that exists to really try to bring together stakeholders to improve the way that infections are managed.
Yep. And when we're talking about antimicrobials, is it antibiotics or is it a broader group than antibiotics?
Yeah, so it's antibiotics and then it's also things like antivirals. So they're all related to the treatment of different types of infections.
And if they're overused, that can encourage the development of pharmaceutical resistant strains of the relevant microbes, is that right?
That's correct.
Such as MRSA and so forth, is that right?
Yes, so you could develop strains of, antibiotics may not work against the conditions that they used to work against.
And this might, for example, have very adverse effects on infection of say, open pressure injuries and things of that kind within an aged care setting. Is that one of the concerns?
I guess if antibiotics aren't working as well, then it's difficult to resolve an infection. Yeah.
You also mentioned influenza.
Yes.
Could you tell the commissioners what the current status of any influenza program is in our country in the aged care setting and what your recommendations would be about that?
I'm sure there's a lot of variation in different areas, but in some of the services that I'm aware of, there is a structured program for staff vaccination, but in some settings it's more dependent on the GP coming to see the resident on an individual basis and prescribing and then arranging for the administration of an influenza vaccine. We know that the Australian Immunisation Handbook strongly recommends that all residents should receive an influenza vaccine to prevent the risk of the flu. But evidence suggests that not all residents receive a vaccination. And of course, obviously resident choice around, the decision about whether they want to have a vaccination is important. But I do also feel that perhaps a more structured approach to vaccination of residents could increase vaccination rates and then therefore reduce the risk of influenza in this setting, which is a cause of hospitalisation and other adverse outcomes such as death.
A disproportionate percentage of the deaths from influenza in the current round in Australia have been residents of care facilities for the elderly. I appreciate they're more vulnerable, but is there a case to be made for compulsory medication, anti-influenza vaccines, both for staff and residents of such facility?
I think resident choice is still important, but I think it needs to be an informed choice. And so I think sometimes having a discussion with a resident or then contacting a family member to discuss the pros and cons of influenza vaccination can take time. And I'm not sure if that time is dedicated across all services for all residents. And so I certainly see that there could be a more structured approach where there could be a more dedicated effort to trying to vaccinate as many residents as possible, but still balancing resident choice and preferences, I suppose.
Thank you, Dr. Sloggett. I'll go now to the fourth risk factor or side effect factor that you've identified from use of medications in the aged care setting, which is weight loss on page 0010. And you've in fact, under that heading, weight loss, referred to a number of conditions which it appears would have an impact on somebody's quality of life, not limited to weight loss, but around other aspects that might affect appetite.
That's correct. So there's a range of different ways that medicines could contribute to eventually a person losing or unintended weight loss. So, of course, if you're taking a medicine that causes you to feel nauseous, you might not feel like eating. If you have a dry mouth or you're having difficulty swallowing because of a medicine, that could also impact on your food intake and therefore lead to unintentional weight loss. And certainly if there's a difference in your sense of taste or smell, which sometimes medicines can impact, this could also reduce the amount of food that you're eating.
And you raise here the need for a residential medication management review in the event that those events occur.
Correct.
If for example, weight loss is noticed.
That's right.
I'll be asking you about those reviews shortly. But this is, in effect, a mechanism by which
certainly
the pharmacist becomes involved and reviews whether the medication regime is appropriate.
Yes, and I guess my point with that section was that there's such a broad range of medicines that can affect your appetite and your food intake, and it sometimes can be difficult to pick out which particular medicines maybe, if any, are contributing, and so that's where input from a pharmacist and their sort of medicines expertise can be beneficial.
Thank you. Let's go to the fifth risk factor, which is the effect of the medications on diabetes management. And in the centre, have you recently conducted a broad literature review? Or?
That's correct. This work was led by one of my PhD candidates, Jackie Stasinopoulos, and we really wrote sort of synthesised information available in the Australian and some international studies to really sort of outline some of the important factors relating to medication management in people with type 2 diabetes in residential aged care.
You refer to the McKellar guidelines for managing older people with diabetes?
Correct.
And what's the thrust of those guidelines as a person with, say, type 2 diabetes is is getting older, they're in their older years, is there a sort of a balancing process that has to take place about?
That's correct.
Yeah,
So
please
traditionally
explain.
when somebody's younger, we might have more intensive management because we're trying to prevent some of the long-term complications of diabetes. So things like macrovascular effects, which are sort of cardiovascular effects, heart attacks and strokes, and microvascular effects, so things like problems with your kidneys and problems with your eyes. So we might manage someone more intensively when they're younger to try and prevent those long-term complications. When somebody gets older and they're in their final months or years of life, their response to medicines can change and their ability to process medicines can change. And people can be sometimes more at risk of the harms associated with medicines. So they may be more at risk of things like hypoglycemia, which is when your blood sugar drops too low. And there may be difficulty recognising when someone is presenting with hypoglycemia. And so sort of the focus of management in those guidelines stresses it's more about quality of life and balancing sort of the symptoms of hyper and hypoglycemia with quality of life.
And just circling back from hypoglycemia to the first risk factor, you've identified falls risks. Is there an association?
Yes, there is. Yes.
Now, you refer in 22E on page 0011 to strategies to reduce the risk of those side effects once this sort of balancing process is occurring and quality of life is assuming a greater importance than preventative strategies in diabetes management. Could you just elaborate on those strategies?
Yes, certainly. So I've identified there that it's important to assess the resident's risk of hypoglycemia, and there is a glucose lowering medicines risk assessment tool in the McKellar guidelines that we've mentioned. It's also important to consider things such as medication reviews, education for residents and staff, looking at whether we can de-intensify or de-prescribe and withdraw some of the diabetes medicines if there's a risk of hypoglycemia and harm. Strategies such as avoiding the use of sliding scale insulin. So when the insulin dose is prescribed as a range and then staff administering that dose will vary the dose based on a person's blood sugar level. And also particular emphasis on looking at medicines management and use of glucose lowering medicines in the final weeks and months of life, because there may need to be changes to a medication regimen in those final weeks and months of life, particularly as your symptoms progress and you've got reduced food intake and things like that.
Dr. Slucker, thanks for your evidence on those 5 risk factors that you've drawn out. Could I just ask you, in effect, a general question by way of a conclusion to that part of your evidence? In effect, you're telling the commissioners that there are risks associated with the prevalence of prescribing of medicines along the lines of those 5 risk factors at least. Do you have any basis at present, do you have any views about whether the levels of prescribing of the medications that produce those risk factors are too high at the moment in the residential aged care setting in particular?
I think we can see that some medicines, the prevalence of use is very high. So, we just looked at the data around psychotropic medicines, which are prescribed to a large proportion of residents. So certainly there is a problem with overuse of certain types of medicines. There are lots of medication-related problems that can lead to hospitalisations and poor health outcomes for residents. And so it's certainly about prevalence of use, but it's about a lot of other factors underpinning the way that medicines are used as well.
This Royal Commission's called, amongst other things, to inquire into the extent of substandard care. Where you have, in effect, the risks outweighing the benefits, in your view, is it reasonable to regard that as substandard care if prescriptions are made in circumstances where the risks outweigh the benefits?
Yes, I guess so. I guess what we need is a mechanism to identify people who are at risk of medicines-related problems and resolve those problems. And so I think we could improve on that process in residential aged care.
Thank you. Could I ask now about the next topic you address in your statement, beginning on page 12 and going for 3 pages, you've identified the issue of polypharmacy in residential aged care, which is something the Commission has heard about. But if you could give the Commissioners a brief outline of your interpretation of polypharmacy and where it becomes a problem, particularly in the aged care setting.
Yes. So polypharmacy refers to the use of multiple medications. So in the general community setting, we generally use a definition of 5 or more medicines on a regular basis, could be termed as polypharmacy. In the residential aged care setting, there's a high burden of medication use, and if we're using polypharmacy as an indicator, if we were to use that definition of 5, it would probably pull up most residents. So in residential aged care, we tend to see a different definition used, and the most common definition used is the use of 9 or more regular medications to define polypharmacy. It's very common in the residential aged care setting to be taking multiple medicines. So we've done some work looking at the prevalence of polypharmacy in the 6 residential aged care services that I mentioned earlier. And we found that 63% of residents are taking 9 or more medicines, so around 2/3 of residents.
And what are the potential difficulties, clinical difficulties, that can arise from polypharmacy if it's not very carefully monitored and reviewed?
So polypharmacy itself, so the number of medicines that you take, has been associated with a range of poor health outcomes in the community setting and also in the residential aged care setting. So an increased risk of side effects, an increased risk of hospitalisations, of falls, of cognitive impairment, a range of those types of poor health outcomes.
Is this because certain families of therapeutic substances have a compounding effect over the other, or what is it?
Correct. So if you're using a medicine that's associated with a risk of falls, there is some evidence to suggest that if you're using multiple medicines or cumulatively higher doses, then you may have a greater risk of falls, for instance.
Right. And are there also other forms of potential interaction between the active agents in these drugs that have to be taken into account, like cancelling effects and things of that kind?
Of course, so there's things like drug interactions where 2 medicines may not mix very well together, and so that can affect the dosing or the types of side effects you might see.
You refer in paragraph 27 to work of Djokonovic and others in connection with identification and prioritisation of strategies to manage polypharmacy in Australia. Now that you've identified quite a few strategies there, are there any you wish to single out as particularly important in your view?
Yes. So I think often people are taking a lot of medicines when they come into residential aged care, so it's something that sometimes starts in the community and continues on. And so I think when a person first comes into residential aged care, it's really important to have an accurate list of the medications that they're using. And so that's why it's important to have medication reconciliation at the point at which people are entering residential aged care. So that's really pulling together a best possible medication list for a resident. And there's good evidence from the hospital setting that pharmacists can play an important role in that process and developing a best possible medication history. So we've got a good starting point. There's a range of other strategies that we've talked about there that Natalie has identified as part of her research. Another strategy is audit and feedback to all stakeholders involved in medication management around the prevalence of polypharmacy in the residential aged care setting. And there's also been mention of deprescribing scripts, which is discussion points that GPs and aged care provider staff and pharmacists can use when talking to residents and family members about polypharmacy. So practical tips and ways that they can approach that conversation. I guess deprescribing deprescribing is the process. I guess all of these strategies are around, a lot of them are around deprescribing. So I should mention that deprescribing is sort of the planned and targeted withdrawal of certain medications. based on after an assessment of whether a person may be benefiting from that therapy anymore. So what are the risks of that therapy? What are the benefits of the therapy? And do the risks outweigh the benefits? And how can we, is the medicine still necessary, and do we need to consider withdrawing it?
This emphasis on deprescribing, it's something the Commission's heard before. Is there a tendency for the decisions that have been made to prescribe on various occasions just to accumulate without a review occurring as to whether the cumulative effect of those medicines that have been prescribed at different times is still appropriate?
That's correct. So it's important to have a regular review as to whether medicines are still necessary. So one point at which that can occur is, at a regular interval when you're rewriting a medication chart, you could, do a review of the medicines. The GP could review the medicines and say, okay, are all of these still necessary when I write up the new chart? Or when a resident first comes into residential aged care, that is a good time to reassess whether all of the medicines are still likely to be necessary and providing benefit.
Dr. Sluggett, the recommendations you've been making to this point are well adapted, if I may say so, to the care of the particular individual, the tailoring of an appropriate medication regime for that person.
Yes.
At the end of this section of your statement, you then take a wider view, don't you?
Yes.
And you propound some recommendations around a broader system of monitoring. Could you explain that to the commissioners?
Yes, so as part of my statement, I have identified that there is scope for a national pharmacovigilance system in residential aged care. So pharmacovigilance is really around surveillance of the safety of medicines use in the broader population. And so I think we could definitely, polypharmacy is one sort of factor that could be monitored, but I think there's scope to monitor a range of medication-related issues that can arise in residential aged care. So that can be the prevalence of polypharmacy, the use of certain high-risk medicines and the proportion of people using those medicines. Also information about medication-related incidents, the proportion of residents who receive a medication review, the prevalence of medication-related hospitalisations. So I kind of see that we could have a national system which draws on routinely collected data, so administrative data, data from incident databases, information from clinical systems that we could pull together to really monitor aspects around quality and safety of medicines use in residential aged care. And that information could be fed back to all the stakeholders involved. So it could be fed back to the individual aged care facilities, the prescribers who work in those facilities, the pharmacists who visit or dispense for those residents in those facilities. And it could be important for benchmarking and understanding where your service fits in terms of other similar services. And also can be helpful for you if that information is fed back routinely, can show you, if interventions that you're implementing locally help to improve medicines use over time.
Thank you, Dr. Sluggett. To a layperson, hearing that there are people who are taking 9 or more medications, therefore meeting the criterion in aged care of polypharmacy, as you've explained it, that's surprising in itself. And then to hear that based on the 6 facility, 383 resident study in South Australia, that almost 2/3 of the people in that study are taking 9 or more medications. That is even more surprising to a layperson.
It's a high burden of medicines use, but I think it's also important to understand some of that. Sometimes polypharmacy is appropriate, and so when we do a structured review of medicines, we try to look if all of those medicines are still providing benefit and are appropriate, and sometimes we can't. It's appropriate polypharmacy, but often there may be medicines which are no longer necessary or could be discontinued. And so it's really important when we're sort of identifying someone with polypharmacy that is a marker, and then we need to do a bit more work around understanding if all of the medicines are appropriate for that person. So that's when a medicines review would come in.
So you're not drawing any inference from the mere fact that the percentage might be around the 63% mark, that in itself is inappropriate. It really needs an individual review in each case. Is that?
Yeah, it's basically a flag. It's a flag to say this person might be at more risk of medication-related harm, so we should investigate this further.
Thank you. The next topic you move to along the lines of identifying what the pharmacist does,
Yes?
and therefore perhaps leading to recommendations about more things that the pharmacist could be doing in this space.
Yes.
This discussion begins at paragraph 15 of your statement. You identify different roles for pharmacists or different categories of pharmacists in paragraph 29. And who are the pharmacists of particular relevance to aged care, both in the community and residential setting?
Yes, that's right. So we have the involvement of the community pharmacists who are based in the community pharmacy. And so they're involved in dispensing and supply of medicines and a range of other activities. They may be involved in the provision of QUM services, so quality use of medicine services, but these services could also be provided by accredited pharmacists. When I talk about accredited pharmacists, which is potentially another group of pharmacists, these are pharmacists who are accredited, who have gone through an accreditation process and are accredited to perform residential medication management reviews in residential aged care facilities.
And just stopping you there for a moment and asking you about another form of medication review, which I believe is now called the home medication review, the HMR.
Correct.
Is there likewise an accreditation required for that purpose?
Yes, so an accredited pharmacist is someone who's gone through an accreditation process and they can provide either and RMMRs and home medicines reviews, HMRs, so the accreditation process is the same.
Thank you. In paragraph D of 29D, you
Yes.
also refer to pharmacists integrated into residential aged care. Is this still something of a rarity?
Yes, definitely.
But you've got a fair bit to say about it later in your statement.
Yes.
Now, in the next section of your statement, you begin to explain this topic of having a pharmacist integrated or embedded
Yes.
in a pharmacy, and later in your statement you refer to this is paragraph 34, the ACT pilot program. What are the advantages of embedding a pharmacist?
I think pharmacists have a real value in identifying medication-related problems and helping to resolve those problems, and also preventing any future medication-related problems from occurring. And so this can be done when you're dispensing a prescription, but I think bringing pharmacists closer to the point of care, the point at which medicines are prescribed in residential aged care, the point at which they are administered in residential aged care, will really help to increase capacity to identify and resolve these medication-related problems that we're seeing in residential aged care.
And have we seen any evaluations of the effects of embedding pharmacists yet, or is it a little too early to tell? We're waiting on that.
There is emerging data from a research trial in Canberra. I have not been a part of that trial, but as part of that study, there was a pharmacist embedded within an aged care facility, and they sort of followed up changes in medicines use and other outcomes associated with that.
And the Commission's also heard about the halt and reduce
Yes.
programs. Now, on page 17, you refer to this concept of embedding a research pharmacist in a aged care provision organisation, and that was a topic you mentioned at the beginning of your
Yes.
evidence. Could you please now expand on that concept and its potential advantages and what gap it might be addressing, gap in data, for example, that it might be addressing?
Definitely. So an embedded researcher is somebody who is employed by a university or an academic institution, but they undertake their work in a different setting or organisation. So in my case, I'm employed by Monash University as a researcher, but I work directly within an aged care organisation, have worked 1 to 2 days per week over a certain number of years. And so I guess this is not a new concept, but it's a relatively unique concept, particularly in residential aged care. And we know that In terms of ageing research, residential aged care is very much an under-researched population, and so it's been estimated in one paper that of all ageing research studies, only 2% are conducted within the residential aged care setting, so definitely an under-researched population. So this is a method that we're using to, I guess, it has a number of benefits being embedded within a residential aged care organisation. It really helps to, when you're undertaking a project to improve medicine's use in residential aged care or in any setting, it's really important to understand the barriers and enablers to changing a practice in a certain setting. And so being embedded within a residential aged care organisation means that I can fully understand some of the challenges in that setting and what some of the enablers to change are in that setting. So it really helps to inform the design of the research, and we can work together on designing a research project that's going to fulfil everybody's needs and answer the research question in a way that works for everybody. It also increases the researchers' knowledge of residential aged care, which is important for understanding what some of the challenges are and translating that research. It also helps to improve the research capacity of the aged care organisation. So they have an improved understanding of what research methods are, what the ethics process involves, how to recruit residents to participate in studies, an understanding of even things like, as part of this research, we use this particular care assessment to assess nutritional status. We don't use that assessment at the moment, we use a different one. What's the benefits and cons of using a different assessment, and sort of asking those kind of questions. So there's a range of benefits both for the researcher and for the research organisation and for the aged care provider organisation. And so I guess it's really about ensuring that putting the research in the best possible way to ensure that it's taken up into practice and translated.
And is encouraging a greater take-up of this model a matter of reaching out individually to service provider organisations and advocacy directly to them? Is that the only way?
I think that could be a way to achieve it. I think increasing awareness among universities and also aged care providers. Some of the providers that I've worked with are very innovative and very interested in research. So I think it's something that is definitely something that we could take this model further.
Thank you. Now I want to turn to a different topic which you begin to address at page 18 of your statement, which is the information flows that are involved, and they're multifactorial, and they move in many dimensions and directions. In paragraph 36, you identify the key stakeholders around the medications management topic, and there's those three kinds of pharmacists that you've mentioned, potentially community, accredited and integrated. But in addition, there are a number of other stakeholders. Could you identify those, please?
Yes, there are aged care provider staff who are involved in administering medicines, also general practitioners who are involved in prescribing medicines. Nurse practitioners may also be involved. I actually I've neglected to mention residents in there as well, and that's an important omission. So residents and also their family members are an important part of the medication management process.
Thank you. And yesterday, the Commission heard a deal of evidence around the risks involved in the current methodology for conveying prescribing decisions through the chain all the way down to dispensing and administration. So
Yes.
I won't ask you about those risks. You've identified that there are risks in that process at various stages of miscommunications. But just focusing on the prescribing decision aspect, this sort of the initiation of the process which leads to administration. Do you have some observations about some features of the current landscape that impact on whether quality decisions have been made?
I'm sorry, could you direct me to which part of the statement that we're currently...
Yes, certainly.
Is this page
At the top
27?
of page 20, paragraph I think it's 37A you refer to.
Oh, yes, okay. So I reflect on that when a person enters residential aged care, there may be a change in all types of their healthcare providers. So their usual GP who is in the community may not be able to continue to provide services to them in the residential aged care facility, so they may get a new GP. They may also have a new community pharmacy, so they won't have any history about what medicines they've used before. And also, obviously, a resident can be new to the staff members when they first enter residential aged care as well. And so I guess I've emphasised that there can be difficulty in obtaining an accurate medication list and also a history of what medicines have been tested before, what's been successful, what hasn't, when a person first enters residential aged care. And I've emphasised the need for reconciliation. So establishing a best possible medication history when a person enters residential aged care.
Thank you. Under the next heading, you address residential medication management reviews.
Yes.
And at the outset of your evidence, you explained to the commissioners that you've actually had many years as an accredited pharmacist.
Yes.
Doing those reviews and indeed doing home medication reviews as well.
Yes, so home medicines reviews and RMMRs as part of residents who were living in a transitional care facility.
Thank you. What's involved in doing one of these in practical terms? How do you go about it?
Yeah, certainly. So with an RMMR, it requires a referral from a GP. It requires a written referral. So that referral may be sent to the community pharmacy that usually supplies the medicines for a resident, or it may be sent to an accredited pharmacist who routinely provides RMMR services at a facility. The pharmacist will look at the review. It will generally have a reason for referral, and it will have sometimes a list of the residents' current medications and some of their health conditions. And this is a referral that's generated from GP practice prescribing software, generally, management software. And then the pharmacist will visit the residential aged care facility. They'll speak to nursing staff and the resident. They will potentially family members. They'll sit down with the medication chart and some of the clinical records, review what medicines are current, and go through each medicine and see and conduct a clinical review basically to see if the medicines are appropriate, if they're at appropriate dose, if there's over-treatment or under-treatment, if the medicines are interacting with each other, and a range of different sort of screening for medication-related problems basically. Then the pharmacist will prepare a report with a series of recommendations on how to improve medicines management for that resident, and a copy of that report will be sent to the GP who provided the referral, and it would also go to the aged care provider as well. And then as part of my RMMRs, I would give the GP a call and ask them if there's anything, or initiate any discussion points, and ask the GP if there's anything they'd like to discuss about the referral or the findings.
Thanks very much. So it involves at least a bilateral process between GP and pharmacist.
It does.
And it involves a great deal of work by the pharmacist, no doubt, but it also involves a decision at the front end to refer, and at the back end to consider deprescribing or represcribing.
Yeah, that's
by the
right.
GP. Is that
So
right?
the GP will then use that information and develop a medication management plan with input from the pharmacist, have a medication management plan for the resident.
And you refer in your statement, I'll come to remuneration for these matters when we come to the end of this topic, but you refer in your statement at 39D to at 39, to a literature review or a synthesis of the published literature about the process and its effects.
Yes.
There are a number of points there. I won't seek to restrict you, but in particular, it seems interesting that the acceptance rate of GPs is quite variable at 39D. What was the nature, what were the other important points that you draw out of that literature review?
This was a literature review that was led by one of my PhD candidates, Isa Chen. And so it was really looking at synthesising information about medication review processes in residential aged care. And we looked over a period of between 1995 and 2018. We found 13 studies, and 8 of those studies specifically focused on the RMMR program. I think one of the important findings of this particular synthesis of the literature is that on average, we know that an RMMR will identify between 2.7 and 3.9 medicines-related problems per resident.
That's 39B.
That's correct, 39B. So it's an important process for identifying potential and actual medicines-related problems, and then also the acceptance rate. So that speaks to resolving some of those medicines-related problems and sort of the value in working collaboratively to resolve those problems.
Thank you. You identify a gap in 39F as well.
Yes.
What should be done in this space?
There is, because of the way the program is run, there's very limited capacity for an accredited pharmacist to follow up after performing an RMMR as to whether the recommendations were implemented and be involved in the ongoing medication-related management plan for that resident. And so, therefore, there's very few studies which have then looked at, I guess, long-term clinical and resident outcomes associated with the RMMR program. So that remains a gap in the literature. But certainly there's a small number of studies that suggest that nursing staff and GPs find the process valuable.
There's a sort of a sporadic nature, is there, to when these reviews are and can be done?
Yes. So the Pharmaceutical Society of Australia has produced guidelines for pharmacists around the provisions of medication reviews in residential aged care, and they suggest, and as does, I believe, the Medicare benefit schedule criteria, suggest that these reviews should be provided as soon as possible after a resident enters residential aged care for the first time.
I'll just put that up on the screen if I may, Dr. Sluggett. Operator, please put up tab 143, item 903 and related information. That's information in relation to item 903 of the Medicare benefits schedule. And is this the information you had in mind a moment ago,
Yes.
Dr. Sluggett? And under patient eligibility, it said that RMMRs are available to new residents on admission into an RACF, that's a residential aged care facility, and existing residents on an as-required basis where, in the opinion of the resident's general practitioner, it is required because of a significant change in medical condition or medication regimen. If we please, operator, go over to the next page under the heading claiming, we see there's a 12-month exclusionary criterion. Just that first paragraph will do, thank you. A maximum of 1 RMR rebate is payable for each resident in any 12-month period, except where there has been a significant change in the resident's medical condition or medication regimen requiring a new RMMR. There's a disparity, I understand, between the remuneration that's available to the GP through item 903 on the one hand and the remuneration that's available to the accredited pharmacist for conducting the RMMR. Is that right?
The program rules for accredited pharmacists suggest that an RMMR can only be funded once every 2 years, unless there is a significant change in the resident's condition and another GP referral is provided.
Doctor, can I just stop you there again and ask the operator to now put up tab 144? Now, this is information in relation to the 5th community pharmacy agreement, and I understand there's now a 6th.
Yes.
However, this was the relevant change to that particular timing criterion, I think. Is that right?
Yes, that's right. So over the life of the program, there's been a number of changes to the eligibility criteria.
And if we go down the left column to the bottom, the heading, what are the program changes from 1 March 2014, it said a number of changes will occur across the 5th agreement programs, and over to the top of the next column, one of those, point 3, is a time frame of 24 months, 2 years, is being imposed between repeat and additional HMR and RMMRs for a single patient.
That's correct.
So has this had, in effect, the effect of withdrawing an incentive on accredited pharmacists to perform HMRs and RMMRs?
Yes, well, it restricts the amount of times that you can visit and provide this service. I guess we know that sort of the average time that a resident would spend in residential aged care is, I think it's roughly around 33 to 36 months, so just over 2 years, or 2 to 3 years. And so in some cases that means that a resident may only receive one RMMR during the entire amount of time that they spend in residential aged care, and that's dependent on receiving a referral.
Now, I won't ask you about any data on this because I don't believe you've got any, but anecdotally speaking, what's your impression of the take-up of the proviso for changed circumstances in which both a GP can refer and a pharmacist can conduct an RMMR or an HMR?
I think there's capacity to increase the proportion of residents who receive a medication review from a pharmacist, definitely. So I suspect, I don't have any hard data on it, that's something that I'm planning to look at within the ROSA registry. But I suspect that medication reviews could be provided to more residents and in a more timely way as well.
Dr. Sloggett, you go on to discuss a number of other topics. I won't ask you, this is page 23, I won't ask you about the National Residential Medication Chart. Commission heard evidence about it yesterday. You do speak to deprescribing for residents of aged care services, but in a way you've already addressed that in your earlier evidence.
Yes.
You then, at the next page, page 24, begin a discussion about simplifying medication use in residential aged care. And at the outset of your evidence, you referred to an ongoing study. It's early in your statement, and it's the GRACE.
Yes, the Simpler study.
Project. Is that
yes,
right?
Mrs. Grace and Simpler. Yes, there's 2 acronyms, correct. So I can speak to that now.
Please
yes.
do. What is the concept of simplifying as opposed to deprescribing?
Yeah, that's right. So what we found from all of our work in residential aged care and spending many time looking at medication charts is that residents are obviously administered multiple medicines, but they can be administered medicines multiple times throughout the day. And we felt anecdotally by looking at medication charts that perhaps we could give the same medicines but fewer times per day. And we hypothesised, well, if residents could have the same medicines fewer times per day, then this could potentially improve their satisfaction with care, could increase their ability to participate in other activities and not have to feel restricted by having medicines multiple times during the day. And it could also, because medication administration is a very time-consuming activity in residential aged care, if we could reduce the amount of time spent administering medicines, then that would free up staff time to provide other types of important care activities. That was sort of the basis of the trial. One way to sort of reduce the complexity of medication use is through deprescribing, and that's withdrawing medicines. Another way to reduce the complexity is really just consolidating existing medicines. So trying to take the same medicines fewer times per day. So using strategies such as administering medicines at the same time rather than spacing them out, or using longer acting forms of medicines, or using combination products to reduce the tablet burden essentially.
Thank you. And have you reached any findings in that study? And
yes.
Is it effective, and does it reduce the risk of errors?
We're still looking at whether it reduces the risks of errors. But what I can say is that, so as part of the study, we recruited 242 residents across 8 aged care facilities. And we had an intervention in 4 of the facilities, and the other 4 facilities were a control group, so they received usual care. So as part of the intervention, we had a pharmacist come into the facilities and use a structured tool, which our research team had developed, to identify opportunities to simplify the way that medicines were given. And the pharmacist went through the medication list and spoke to the residents and staff and made some recommendations about how to make medicines use simpler. Then these recommendations were forwarded to the staff and to the GP for consideration and implementation. And so what the pharmacist found was, as part of that process, was that 2/3 of the residents could take the same medicines in a simpler way. And then we,
which in itself is a finding that simplification is effective because you're saving time in the manner you
that's
described.
right, yeah, that's right.
And are you still looking at whether by doing so you're reducing administration?
Yes, well, we've seen at 4 months there is a significant reduction in the number of administration times, which was the primary outcome for this study.
Thank you very much. Now, the next topic you deal with involves medications management and administration errors. It commences at the foot of page 26. And again, I'll mention that the Commission heard evidence from Professor Westbrook yesterday about error in communication of the information regarding prescription through to the point of dispensing and administration. But Professor Westbrook wasn't speaking to the quality of the decision made to prescribe,
Yes.
or the particular mechanics of administration. Now, I've already asked you about the quality of the decision making, and you've addressed a number of points regarding that and the prospect or the potential for errors to occur in that respect.
Yes.
You've identified more detail on that in paragraph 48, but is there anything in particular that you wish to highlight there that you haven't already explained to the Commissioners?
I think I've highlighted there that errors can arise when the person is making the decision to prescribe and selecting whether a non-pharmacological strategy or a medicine is necessary, and then selecting which medicine to prescribe and which dose to use, and how long do we wait for reviewing. And so I think that's an area where problems with medicines use can arise. And so at the moment, we know that there's a lot of separation between the important stakeholders in medication management, and community pharmacists and pharmacists are based off-site. And so I see a role for, pharmacists working in a collaborative way with GPs at the point of care, at the point of prescribing, to inform and work together to improve that process.
At the other end of the process, where you're storing and administering medications, on page 29,
Yes.
beginning at paragraph 52, you refer to storage and distribution, and 53, perhaps even more pertinently, administration, the potential for errors there. Are there particular issues there that you could highlight for the Commissioners?
Yes, the issues that I've raised there, that there's a lot of time spent administering medicines, and sometimes medicines need to be altered before they're given, so by ways such as crushing. And so there's also issues around giving particular medicines at a certain time, and that because medication rounds are quite long, there's a risk that some medicines won't be given at the exact time that they're prescribed. And often that may not be a problem, but for a small number of medicines, there are time-sensitive medicines where that could be a problem. So I've talked about those types of issues.
Just stopping you there, crushing is actually risky, isn't it? You've said you need a great deal of knowledge to know which can...
Exactly. You need to know whether it's appropriate to crush a medicine, because it involves safety for the resident but also for the staff member. So safety for the resident in that if you crush a medicine with a particular coating, if you're getting rid of that coating, the medicine may not be able to work anymore, but it also could cause side effects. So crushing... if you're crushing a slow-release medicine that's supposed to release over, say, a 24-hour period, if you're crushing it, then it means all of that dose could be delivered at once, and so it's putting a resident potentially, depending on the medicine, at risk of side effects.
Yep. Thank you. And look, I won't ask you to comment on all of the matters you've addressed in your statement, but they'll certainly be given full weight and taken into account.
Thank you.
If we could... finish with the final topic of your statement, beginning at page 32, on the connections between the medication management issues you've mentioned and quality of life.
Yes.
What are your reflections in this regard?
I guess I've reflected on the fact that medicines can have a range of different side effects, and so they can impact on quality of life for a resident potentially. And so I've really discussed types of examples of when that may occur, and how changing the way that medicines are given or changing the types of medicines could improve quality of life potentially.
There was one part of this part of your statement which I found particularly moving, I suppose, and it's in paragraph 61 where you in effect make a plea for forethought and consideration about what the choices of the resident are when looking at the medications they're being prescribed on a regular basis. For example, if they're going to go out on a special outing the next day, think carefully about whether the usual medical regimen, which might include diuretics, is appropriate.
Yes.
And I suppose there are myriad examples of that kind, but do you have any reflections on really what's needed here to achieve a
Yeah, I
person's
agree. I
goal?
think having a good knowledge of the resident and also a good knowledge of medicines is really important to inform those kind of decisions, and taking the time to have a discussion with the resident about their preferences as well. And so I see a key role for pharmacists in those types of activities.
Commissioners, I have no further questions for Dr. Sluggett.
Dr. Sluggett, I found your evidence today incredibly interesting. There are many things that arise from it, but I think Council has covered most of them. I just wanted to go back to the early charts you showed about the incidence of prescribing of certain drugs on entry and for the first 12 months afterwards. You don't have to bring up the chart. What that chart said to me is that we've got an issue more generally around people's expectations that drugs will manage behaviours. So if you're struggling at home with somebody who's got dementia, you go with that person to the doctor and seek to get something that can control their behaviours. Similarly, when they enter a residential care facility, they're disoriented and so forth, and they get drugs to control their behaviours. This is a serious, you're nodding, this is a serious societal question and runs to something we've heard evidence about managing behaviours through alternative mechanisms. And I think, am I right in saying that the conclusion of that part of your, one of the conclusions of that part of your evidence is that there needs to be wider community education and understanding about what some of the non-pharmacological alternatives might be?
That is definitely one of the most important points. I think we also need to have education and also support for people in training around, potentially around in training about non-pharmacological strategies and how they can be used and should be used, and that, you know, that should be the mainstay or the focus of treatment.
Maybe I can throw in a second one. The thrust of the latter part of your evidence was around the reviews, the
Yes.
medication management reviews. And from reading your statement and hearing your evidence, you believe that there should be a review when somebody enters residential aged care, and then you say more often than each 2 years. But given that chart where we've got the increase in incidence of prescribing and then it levels out for the most part, would a review 6 months after that entry be appropriate, or what have you or the society got in mind?
Well, I can only speak for myself, but I think it's about tailoring a medication management plan to an individual resident. So having flexibility in that the pharmacist and the GP can determine a plan as to, okay, the pharmacist will re-review this person at a certain point in time. So I guess having flexibility for an individual resident to see whether, so the pharmacist will make some recommendations and to see, well, if we implement this, let's monitor and see what happens. And so I think it really needs to be tailored to an individual resident and have flexibility.
Okay, and at the moment we don't know, do we, how many people have a review of their medications on entry?
No, we don't. And so that's work that I've just started to commence with the Registry of Older South Australians, yes.
Thank you.
Thank you.
Anything arising, Mr Gray?
No, thank you, Commissioner.
Professor Sluggard, thank you so much. I join my colleague in thanking you for the very detailed exposition of the importance of pharmacy in dealing with people in aged care, and we've certainly learned a lot about what should not be done, and you've given us some clear guidelines as to what can be done to improve the situation. We're very grateful to you for that. Thank you.
Thank you.
The Commission will adjourn until 1:15.
Australian Royal Commission now adjourned to 1:15 p.m. Please be seated.
Here's Mr Knowles.
Yes, thank you, Commissioners. We have Catherine Maloney in the witness box as the next witness.
I solemnly and sincerely declare and affirm
I solemnly and sincerely declare and affirm
that the evidence I shall give
that the evidence I shall give
will be the truth,
will be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Ms Maloney, can you tell the Commissioners your full name for the transcript?
Catherine Mary Maloney.
And you have prepared a statement dated the 30th of May 2019.
Yes,
Yes, and you have a copy of that in front of you there.
I do.
And that is numbered WIT.0198.0001.001. Ms Maloney, have you read your statement lately?
I have.
Yes. And are there any changes that you wish to make to your statement?
No.
Thank you. And are the contents of your statement true and correct to the best of your knowledge and belief?
They are.
Thank you. Now, Ms Maloney, you're currently employed as the Acting Chief Executive Officer of Services for Australian Rural and Remote Allied Health,
That is right.
otherwise known as SARA.
That's correct.
Yes. And what are your qualifications?
I am a physiotherapist by background.
Okay. And what did you do before your present position at SARA?
I have so previously worked at Nunapa Health Council as General Manager, and prior to that, over a 10-year period, had a range of health management positions where I was overseeing allied health teams, providing services into hospital, subacute and aged care settings.
Before I proceed any further, if I might just tender Ms Maloney's statement.
Yes, certainly. The witness statement of Catherine Mary Maloney dated the 30th of May 2019 will be Exhibit 6-33.
Thank you, Commissioner. Now, can you tell the Royal Commission precisely what SARA does?
SARA is a member-based organisation, a peak body that represents allied health professionals who live and work in rural and remote Australia. SARA exists so that rural communities have equitable access to allied health services to support their well-being.
And you say it's a member-based organisation. Who typically are the members of SARA?
They will be allied health professionals working across public, private and not-for-profit sectors.
And are you yourself a member of the organisation?
I am, yes.
Now, you mentioned that its role, or at least part of its role, is to promote equitable access to health services in rural and remote areas, and particularly those services as provided by allied health professionals. You've given some evidence in your statement about access to allied health professionals contributing to better health and quality of life outcomes. Can you just elaborate on that for the Royal Commission as to how, by reference to particular disciplines, that occurs?
Certainly. Allied health professionals come from a range of disciplines. So in terms of health benefits and in terms of the aged care setting particularly, speech pathologists have a role in identifying and managing communication issues and dysphagia issues, speech and swallow issues, and the prevention of difficulties arising from those areas. If swallowing difficulties, for example, are left untreated or not managed properly, they'll result in chest infections, malnutrition, dehydration, weight loss, and in some cases, aspiration and death. Allied health professionals such as occupational therapists, psychologists and diversional therapists can assist in the management of neurodegenerative conditions such as Parkinson's disease, dementia and stroke. Allied health interventions can mitigate the impact of challenging behaviours, reducing the incidence of falls and make substantial contribution to the quality of life of older Australians.
You've also referred in, I think, paragraph 6 of your statement to other disciplines such as dental hygienists and oral health therapists who provide assistance with oral health care, and that's at the bottom of page 2 in the last dot point there.
Yes.
What type of conditions can they be used to treat? And what are the side effects if they're not used properly?
So they can provide assistance with oral health care, conduct oral health assessments, and prepare oral health care plans, facilitate referral to dentists. The issues that might arise if older people are not accessing these services are things like reduced nutritional status because people are unable to eat properly, and the other associated health conditions arising such as cardiovascular disease.
You've also mentioned across the page in the last dot point under paragraph 6 the position of allied health assistants. What are those people and what role do they play in the provision of care services to older people?
Allied health assistants are Certificate 4 qualified assistant workers who work under the direction of allied health professionals to carry out the care plans required to meet the needs of patients or older people living in aged care facilities. This supports the work of the allied health professional by allowing the allied health professional to focus on the higher complex clients that they might be treating, and so the assistants are in a position to undertake the more routine work that allied health professionals prescribe.
And have you yourself, not necessarily in the aged care setting, observed a model of service delivery using allied health assistants?
Yes, I was involved in a pilot project that began in 2009 in New South Wales that looked at the implementation of allied health assistants working across disciplines in rural settings. So an example would be an allied health assistant embedded in a multi-purpose site in a rural community and undertaking work prescribed by visiting allied health professionals. So where you didn't have an allied health professional embedded in that facility and providing an outreach service to that community, the allied health assistant would undertake the prescribed care by that allied health professional. So that enabled an increase in frequency of the allied health services that were being delivered and better continuity of care for the clients, the recipients of that care.
Am I right in understanding that what sets your members apart from other allied health professionals who do the same sort of work is that your members do it in rural and remote Australia?
That is correct.
And in relation to allied health assistants, did you see, you've referred to some benefits there in terms of the way in which that increases the ability to provide regular allied health services to people in rural and remote areas. Mm-hmm. What potential do you see for people occupying those allied health assistant roles in terms of their ability to work in a range of disciplines?
What we observed during that pilot was that the assistants in those roles had vision across the various allied health professions that they were operating under the supervision of. So for one particular client, that allied health assistant might be working under a physiotherapist and a speech pathologist and a dietitian, And so they were in a position to see the combined effect of those various allied health interventions. So this has a number of benefits in terms of the quality and the continuity of care that those clients are receiving, and the allied health assistant is in a position to make a determination as to whether or not a client is progressing against a care plan as expected. And part of that allied health assistant's role is to report back to the professional with regard to the client's progress against that care plan. I think a future role for the allied health assistant is that, given this exposure and this experience, their role in care coordination for complex clients who have, for example, chronic disease is quite significant. At this point, I think that the allied health assistant workforce is still evolving, and so the capacity to take on these roles is not quite there yet, but I think this is an important development that allied health assistants could, it's an important role that they could undertake in the future. And the importance of that is that it would free up other health professionals working with a client to focus on their scope of practice, and that would include the nursing staff that might be involved in a person's care.
And so is that model that you observed one which, so far as you're aware, is employed in aged care?
Yes, so what I have seen is particularly in multi-purpose sites, so where you have both acute care and aged care services being provided, you will have an allied health assistant who is located and employed within that facility and is undertaking care provided by the visiting allied health services into that community.
How common is it in terms of its use in the aged care setting?
I think it could be a lot more prevalent than it is. So I think that there are probably pockets of care where that is occurring. But I think that there is significant scope to embed that practice and that model of care into the aged care setting.
And I take it particularly in a rural and remote setting where there are potentially fewer people of those allied health profession disciplines available to the population.
Yep, absolutely. Ideally, we would like to see allied health professionals being accessible to all aged care settings. But in practical terms, in rural settings where that's not possible, allied health assistants are an important part of improving access to allied health services.
Now, if I can return to your statement, and in particular paragraph 7, and there you refer to some research undertaken by Sarah in respect of cost savings of use of allied health professionals where there is a strong preventative focus on the part of those professionals. Can you give the Royal Commission some details about that research?
Certainly. This piece of research was undertaken because there is a relative lack of research into the impact and the value of allied health services in general, and that speaks to it having lesser presence in research agenda more broadly. And in part because of that, this is a literature review of existing research that was able to identify 8 interventions where allied health services are involved. And as a result of that, the findings of this report probably are a conservative estimate as to the relative benefits of allied health services. So the 3 key areas of research that are talked about with this report include diabetes, where the cost benefit was in reducing the negative outcomes associated with diabetes, including cardiovascular disease, eye disease, kidney disease, and the rate of amputations. In osteoarthritis, what was seen, the cost benefit was seen in the reduced rate of joint replacements for people accessing allied health interventions for the management of osteoarthritis. And the third area was in stroke, and the cost benefit there was realised in the reduced admission rate to residential aged care facilities. So in general, this study showed that $175 million per annum could be made in annual savings through preventative care measures provided by allied health services.
And as you, I think, just pointed out, that was a saving, but only through 8 particular allied health interventions. Other allied health interventions conceivably could have led to further savings.
That is correct. So this is a very conservative estimate as to the potential savings to be made.
Can I-
as opposed, in addition to the improved quality of life for clients.
Indeed. Can I ask why there were only 8 allied health interventions that were looked at?
Because they were the only ones that met the requirements for the literature review. So there was a lot of other data out there that for the purposes of this literature review did not meet the requirements.
Right. And when you say there was a lot of other data, is there a lack of accessible and data that can be interpreted properly in terms of allied health professionals' use and take-up in the broader community, but particularly in aged care?
Yes, so in general, the research funding that's available for the allied health services, and particularly around cost benefit and the impact, is very small compared to the larger research agenda. So what this means that there is not the level of available information about allied health services and their impact that there are for other parts of the health workforce.
I see. And does that have an impact on the ability to undertake research into the benefits or otherwise of use of allied health professionals?
Yes, absolutely. So it has that impact. The other issue is that we do not have access to the same level of information regarding the allied health workforce. So the impact in terms of being able to plan and incorporate allied health services into future planning for health and aged care is restricted because of that.
You've also referred in paragraph 8 of your statement to other research conducted by Sarah on the use of allied health professionals to avoid further interventions, which I take it is in some ways related to the research, the subject of paragraph 7. But can you just tell the Royal Commission what that research showed in terms of use of allied health professionals at an early stage?
So this research, that there are a few areas that we can refer to. For example, a podiatry clinic running Queensland between 2009 and 2010 resulted in nearly 50% reduction in non-urgent waiting list for orthopaedic foot surgery. And then in terms of osteoarthritis management, a multidisciplinary team comprising a physio, occupational therapist, dietitian, orthotist, social worker and rheumatologist were able to reduce the demand and the waiting list for joint replacement surgery by 15%.
I see. So again, this is an example of research going to the savings and avoidance of further costs down the track.
That is correct. Yeah.
And in terms of these pieces of research that you've referred to in paragraph 7 and 8 of your statement, neither of them is confined to an aged care setting. Is that correct?
That is right.
They're looking more broadly at the use of allied health professionals in the community.
That's exactly right, and in particular with regard to health benefits and savings to the health system.
Yes.
The sequelae there, though, is that by maintaining people in the community healthily for longer, you will avoid the costs associated with admission to an aged care setting.
And the research, on the other hand, that's referred to in your statement of paragraph 9 was focused on residential aged care facilities, wasn't it?
That is right, yes.
And can you just tell the Royal Commission about that research and what it entailed?
So this looked at the input of oral health professionals in residential aged care facilities. It highlighted that staff in residential aged care facilities may not be appropriately trained or not comfortable in delivering oral health care, and despite training, were still unable to provide an adequate level of care. So the conclusion of that particular piece of research indicated that oral health professionals, in this instance, should be embedded in a multidisciplinary team in an aged care setting.
And can you tell the Royal Commission, broadly speaking, what you see as the significance of research, such as the research that's referred to in these paragraphs of your statement, in respect of the use of allied health professionals for aged care?
So I think that in general, allied health professionals are underutilised in an aged care setting, that multidisciplinary care is critical to quality of life for older people, and particularly older people who have multiple morbidities and complexity, and that their presence in an aged care setting has, there is evidence to suggest that this will improve the quality of life for recipients of aged care services.
And do you take this research to also present a basis for suggesting that there may be economic benefits for the use of allied health professionals in aged care?
Absolutely. So, yes.
Now, otherwise, you've referred at paragraph 10 of your statement to the maldistribution of allied health services between, on the one hand, urban areas and on the other hand, rural and remote areas. And you describe there the research that was undertaken by Sarah, and it's referred to in footnote 6 of your statement. Can I take you just to the cover sheet of that? It's at tab 115 of the General Tender Bundle, document number RCD.9999.0096.0113. Now, do you see that, Ms Maloney?
Yes.
Can you tell the Royal Commission what the aim of that research was?
The aim of this piece of research, again, a literature review, was to look at the evidence base for strategies that improve the recruitment and retention of the allied health workforce in rural settings.
And I take it from that aim that it was responding to a perceived lack of allied health services in rural and remote settings.
That's correct. So the paper will, it explores the maldistribution of the workforce of the allied health workforce in rural and remote Australia. It draws comparisons, for example, with the medical workforce. And so what we know is that allied health professionals, when you break it down by profession, are less numerous than general practitioners, and it is at a similar level to specialist medical services in terms of the access by head of population. The paper then goes on to look at the sorts of mechanisms that might improve the number of allied health professionals available to rural and remote communities. And it takes a pipeline perspective, so looking at looking at the growth of the allied health workforce, right from student undergraduate programs that look at early exposure to rural clinical placements as part of your undergraduate program, rural quotas for students of a rural background, because the research tells us that they are more likely to come back and practice in rural areas. Looking at the support requirements for early career health professionals so that they get a good exposure to quality allied health services in their early years, and then the ongoing supports for allied health professionals as a mature professional, which may include pathways to specialisation and linkages to universities and academic research.
And to your knowledge, what is the extent of implementation of those suggested approaches to improve access to allied health professionals in rural and remote areas?
I think if the recommendations made in this document were to be taken up, that we would see a substantial improvement in the number of allied health professionals returning to practice in rural and remote settings. And I think the fact that we've had to bring this paper together in the first instance demonstrates a relative lack of focus on the allied health workforce in comparison to medicine and nursing over decades. So if we can pick up and provide similar levels of support to the allied health workforce across all of those disciplines that we have seen for nursing and medicine, that we will make some changes there, that we will see some improvement in that distribution of the workforce.
Now, Ms Maloney, you're aware that there has recently been a National Rural Health Commissioner's request for feedback on a discussion paper for consultation in respect of rural allied health quality, access and distribution.
That's correct.
And that document is at tab 135. If that could just be brought up on the first page. Sorry, that's not...
No, that's not it.
That's not the document. 132, pardon me. Thank you. Now, is Sarah going to be providing a submission by way of feedback in respect of that discussion paper?
Yes, we will. So this document was released a week ago, and we are still formulating our formal response, but we will be certainly, along with a range of other peak bodies, developing our own response to this document.
And in terms of that response, are you able to indicate any aspects of it at this time?
Sarah largely endorses the policy directions suggested by this document. In particular, in terms of its relevance to the aged care setting, I'd like to look at policy area 3.
Yes.
Which looks at the...
And that is at page 0.0035, I understand.
Page 24, structured rural training and career pathways. One of the concepts that Dr. Worley's paper refers to is the concept of allied health rural generalism, which for the allied health disciplines is about a particular discipline, so a physiotherapist or a speech pathologist working within their scope of practice, but across a breadth of conditions and client populations. And this is relevant for rural and remote settings because in order to meet the needs, the health needs of that community, a health professional will need to consider every aspect of that community's needs from birth to old age. And so a rural generalist pathway supports the development of allied health professionals to be able to deliver services that meet rural communities' needs.
Thank you, Ms. Maloney. Now, was there anything more that you wish to say about that particular request for feedback before I move to another area?
Just that, in addition to that, Dr. Worley does talk about allied health assistance, and so again, that strengthens the argument that the role of the allied health assistant under the direction of an allied health professional will go some way to meeting the needs of rural communities.
Yes. Now, in your experience, including the work experience that you described earlier, have you observed the delivery of allied health profession services in remote areas, not just rural, but actually remote areas?
I have, yes.
Yes. And can you give some description of that to the commissioners?
So I spent 6 months of last year working on the APY lands for an Aboriginal community controlled health service that included an aged care facility. And so my observation there was that while that service was of a good quality, culturally appropriate, again, access to allied health services was severely restricted. So the capacity to bring allied health professionals into that community and that facility was very restricted.
How did it work, in effect, in terms of bringing allied health professionals in to attend to people's needs?
It would be on a referral basis only, and there would be delays in terms of when that service was accessed because it would depend on the small team that was providing services onto the APY lands, the timing of that. So there may be some gap between a need being identified and a referral made and the access to that service.
Were there any allied health assistants working?
No.
No. Do you see that they might have? Do you think that they might have been of benefit in this circumstance?
Absolutely. So again, and I think the cultural issues around providing services in those settings would be paramount. So even the existence of Aboriginal health workers as a prime need in those communities would improve primary healthcare standards for remote communities. But then as an extension of that, allied health assistance or Aboriginal workers with allied health assistance competencies would then be able to support the work of allied health professionals providing outreach services.
Was there telehealth used at all in that particular setting?
No.
No. And can you talk to the Royal Commission about telehealth and the benefits that you see that that would provide for the provision of aged care in rural and remote settings by allied health professionals?
Certainly. Again, ideally, all people should be able to access services directly, face-to-face with an allied health professional, but where that's not pragmatic or possible, telehealth can be used as an adjunct to services. So there's a number of ways in which this can happen. An assessment, so telehealth can be used to increase the adherence to a program after an initial assessment has been made by an allied health professional. So the follow-up appointments and sessions can be conducted by telehealth. In addition to that, you can have some assessments undertaken by telehealth, but you would need to have somebody at the patient end of that exchange to assist the patient, but also assist the therapist in undertaking certain assessment procedures. And in some circumstances, telehealth may be the preferred mode of service delivery. For example, psychological services, there is evidence to suggest that they are quite effective when they're delivered by telehealth. So it's a combination. Again, I would stress that direct access to allied health services would be ideal, but there should be more availability of telehealth services in general. With regard to aged care settings, the sorts of things that I have seen would be the use of telehealth at the bedside for an aged care resident accessing general practice services. So where there wasn't a GP available to attend the residential aged care, that's done by telehealth. So I have seen models of that occurring. And so by extension, under certain circumstances, telehealth delivered by allied health professionals could be undertaken as well.
And you refer earlier to having an allied health assistant, having someone else to assist with the telehealth at the actual facility.
Yes.
If that were an allied health assistant who had abilities across a range of allied health areas, that would, I presume, go some way to allowing a multidisciplinary approach to be provided from time to time by telehealth.
Yes. An allied health assistant embedded within an aged care team would be in a position to assist with those telehealth consultations, as well as, because they are working under those allied health professionals, be in a position to kind of pick up where those services might be required and request assessments to be made, either because there's been a change in somebody's functional status or they're not progressing as they would be expected to.
From your experience, would you say that allied health professionals and allied health assistants are properly utilised in aged care generally?
In my direct experience, I would have to say no. I think that allied health professionals are underutilised in the first instance, and I think that there's a number of reasons for that. I think that that because workforce profiles do not always incorporate allied health professionals, they are not involved at the assessment point. So when a client is being admitted to an aged care setting, it's not standard that allied health professionals are involved in that. And so I think that a lot of care needs for that individual may not be picked up on admission. Following on from that, I have observed that the care needs, or where there's a change in somebody's condition, that the benefits to allied health services may not be identified, and therefore those referrals are not necessarily made. So in rural settings where access to allied health services are difficult, the needs aren't identified, and even if they are, sometimes because the staff are used to the fact that there's just not that access, or it's not easy, that those services are not requested.
Just going back to you saying that the needs are not identified, does that relate to a lack of knowledge of the effectiveness that allied health professionals may have?
Yes, but also that something can be done about something. So I guess an example would be with regard to communication issues, that where that might be just accepted, that a client has a communication issue, that there is something that can actually be done about that. And so if they had adequate access to allied health services, that might be improved.
How does one raise awareness of the impact that allied health professionals may have in terms of those, say, communication issues that you refer to, or other difficulties that a person may be experiencing?
if we had access to a truly multidisciplinary team that had input from relevant allied health professionals, I think that would have a positive impact on the rest of the clinical team and non-clinical team that are supporting that client. So some of it is about the fact that allied health professionals, and again I'm talking in terms of rural and remote settings, are providing services on a sessional basis, and they're not part of the care team surrounding that client. And so the opportunities for the care team to understand the impact of allied health and understand when it's appropriate to refer is restricted because of that.
And when you say that sessional basis, is that's a reacting to a problem that's been identified, or is it a regular
That is
attendance?
so. It can either be, it's generally by referral. So from my observations in rural settings where you don't have an existing allied health service, when it's identified that a particular assessment is required, that is made on a referral basis. But at best you will have a sessional allied health professional providing a service to an aged care facility. And again, the observations leading from that are that an allied health professional may undertake an assessment and make care plan arrangements for a particular client, but if the facility doesn't have the appropriate skills or the resources to carry out those care plans, then potentially nothing will happen between one session and the next.
Now, you've also mentioned in the context of use of allied health professionals in aged care in rural and remote areas the issue of funding arrangements. And do you see there being deficiencies in that area yourself?
Yes, so I guess the sorts of things that we've just been talking about in terms of allied health input and the opportunity to be involved in the assessment of older people as they're entering aged care facilities, the funding doesn't support that, and so that has an impact on the care planning arrangements for that client. And in addition, because the funding arrangements vary depending on what level of care a care recipient is eligible for, that results in a degree of confusion about who can access allied health services under the ACFI and who may not. And so I think that is a barrier to access to allied health services for the care recipient.
And how would you propose that be remedied?
I would suggest that allied health services should be accessible to all older people who are accessing aged care in general. So access to allied health services is an integral part of a person's capacity to maintain a quality of life. The impact of not having that access when somebody goes into care is that where they may have been accessing rehabilitation, for example, before they enter into an aged care facility, that ceases as soon as they go into an aged care facility. And so there is the risk of functional decline occurring as when somebody enters into an aged care facility.
Do I take it from that you're suggesting that funding models as they exist are quite reactive to decline rather than being funding models that promote preventative measures and prevent decline?
The current funding model, in my experience, does not support the ongoing functional capacity of an older person. So the importance of maintenance rehabilitation, for example, or the importance of effective management of challenging behaviours through access to allied health professionals with particular skills in that area, the current funding instruments don't support that generally.
We were talking earlier about telehealth, and I think you've said in your statement that there is funding available under the Medicare scheme for telehealth by general practitioners. Is that right?
Um, I think there's been recent changes.
Yes.
Yeah, to improve the access. So until recent times, the telehealth was accessible for specialist to GP,
I see.
but not necessarily GP to patient.
I see.
So the models that I've observed were actually funded by a third party that were implementing a pilot.
Right. And do you see that as being something that would be the subject of a funding model to promote allied health professionals having access to rural and remote areas?
Absolutely, yeah.
From your perspective, what would be an ideal model of care at a residential aged care facility that incorporates an emphasis on allied health?
In rural and remote
Yes.
settings, yeah. I think that you need a multidisciplinary team supporting the care of those residents. I would advocate for the inclusion of an allied health assistant as part of that workforce profile on a significant employment, so at least full time, depending on the number of residents in that facility, to undertake the prescribed plans by allied health professionals. So where it may not be feasible to have the complete multidisciplinary team in an aged care facility in a rural setting, the allied health assistant can work across those professions to deliver services to aged care residents. In addition to that, I mentioned earlier that the role of the allied health assistant is still being developed and there's still capacity to grow. At the moment, for example, we have allied health assistants and leisure and health assistants who are focused on the social programming for residents of aged care facilities, and I would advocate that those roles would be merged so that you are getting the best of both of those roles to support the social and emotional well-being of residents, but also their physical and functional needs to stay well.
Yes. And do you have a view about what the clinical governance arrangements might be in that setup that you've just described?
So I think there needs to be a dedicated allied health assistant component there, and because, again, my observation is that the role is often tagged on to an assistant in nursing or an enrolled nursing role, so they're not necessarily have the formal qualifications to undertake the care plans as directed by allied health professionals. And in addition to that, that person has conflicting priorities, so that in an MPS facility, for example, as soon as there is a high acuity patient in the facility, attentions and resources are directed there at the expense of the aged care residents in that facility. So by having a dedicated workforce that sits within the aged care component of that facility, you are going to improve the current standard of care for aged care residents.
Some of this you may well have covered, I suspect, in your evidence thus far, but can you tell the Royal Commission what you think can be done overall to improve the situation for delivery of allied health services to people in aged care in rural and remote areas?
So I think clarity around funding for the aged care managers of aged care facilities to ensure that residents can access services as they're needed. Allied health professionals being part of the assessment process, and
Just before you go on
Sorry?
from that, can I just ask you about clarity of funding? At paragraph 25 of your statement on page 7, you refer to the design of a funding mechanism that supports quality multidisciplinary care for older people with complex needs residing in aged care facilities. What would some of the characteristics of such a funding model look like?
So I think you need that broad-based assessment or access to allied health at the point of entry. And the current funding mechanisms don't support that. So it needs to be a more blanket approach, I think, that at least at the point of entry you've got that multidisciplinary care. So in terms of clarity, it's about if somebody is at the point where they are needing aged care services, whether it's community-based or in residential settings, that allied health services are a part of that, I think is the ideal position, because to make it an optional item risks underutilisation, and that's the current situation that we have.
And was there anything else before you move to the next issue about improvements that you wanted to say about funding? In paragraph 21, you make some other observations about funding arrangements and funding models. Is there anything you wish to elaborate on in terms of those matters there?
So I've spoken about embedding allied health services into the funding instrument, and we've also talked about flexible funding arrangements for rural and remote aged care providers, blended funding models, and private sector engagement. So there's a number of different strategies involved there to look at improving the viability of allied health services that are existing in rural communities at the moment. So it's partially about funding, so that an aged care provider might engage a private sector allied health professional in a way that is viable for that allied health professional to take up. And so that speaks to arrangements under MBS or DVA, for example, to make it viable for that person to leave their clinic and go into provide an in-reach service into an aged care facility. Or for an aged care provider in collaboration with other health service providers in a community to look at pooling their funds in order to attract allied health professionals to provide a service into those communities. And there are some good examples of where that happens at the moment.
Those good examples being?
So there is an example where a health service has pooled funds with a primary health network and to commission a private sector allied health professional to provide services into rural communities where there were no previous, in this instance it was a physiotherapy service. So what that enabled is those townships to access services across a range of sectors, so chronic disease management, primary health care in general, the acute hospital setting and aged care. And so, but that's unusual, I guess is the point that I'm making here. So seeing more of that would enable allied health professionals who are working in the private sector to think more broadly about the services that they're providing.
Aside from funding, what other improvements, and I interrupted you, apologies, what other improvements are there that you see as being capable of being made to the provision of aged care in rural and remote areas by allied health professionals?
So we talked a little bit about the inclusion of maintenance rehab as an important part of service provision to people in aged care. So at the moment, that doesn't really happen. If somebody has been has had some sort of health event, has gone through the hospital system, undertaken a period of rehab, and for some reason has then been admitted to an aged care setting, all of those rehabilitation services then stop. And again, my observation is that you see a functional decline as soon as that person goes into that aged care facility. And some of the gains that were made as part of a subacute care phase is lost when they enter into an aged care setting. So some arrangement that provides for the continuation of what I'll call maintenance rehab to maintain that person's function would be a critical part. And it does, I'm not saying it doesn't happen, but where you don't have allied health professionals embedded in the staff or in the services there, then you will see that functional decline. In addition to that, the importance of social programming is something that needs to have more weight, I think. Allied health services can contribute to the social and emotional well-being of aged care residents through tailored programs that support not only their social well-being, but can also be very important in managing challenging behaviours. So there are a range of services that allied health professionals can take on that would reduce reliance on medical interventions, pharmacological interventions, for example, in managing the health conditions of aged care residents.
And would an allied health professional in the nature of a diversional therapist be one such person who might provide that service?
That's correct. And if I can just clarify that diversional therapists are one of those more recently emerged allied health professions. So they are degree qualified to the Australian qualification standard at level 7 and above. So when I speak about diversional therapists, I'm speaking to that cohort, because there are diversional therapy assistants and diploma qualified diversional therapists that are employed and working within aged care facilities, but I'm speaking to the allied health professionals with the degree qualification.
I understand. Are there other matters that you would like to mention now by way of potential improvements to access and availability of allied health professionals in aged care in rural and remote areas?
Just coming back again to the ACFI as the funding instrument for residential aged care, ensuring that amendments allow allied health professionals to provide evidence-based care. So the particular item that I'm referring to there is in Domain 12, the complex care domain, and specifically pain management. That does not reflect current evidence-based practice and is quite restrictive in terms of how high quality care might be delivered to people in aged care settings.
And why do you say that doesn't reflect current practice?
It is because it refers to passive treatment modalities that do not reflect the current evidence base in the management of pain.
Was there anything else that you wish to say by way of ways in which there may be improvements made to the provision of aged care by allied health professionals in rural and remote settings?
I think we've covered it. Thank you.
I don't have any further questions for Ms. Maloney.
Ms. Maloney, I'm going to ask you to help me, if you would, as to the sort of practical problems that confront an allied health professional on the ground in remote areas. And I think you said you spent 6 months of last year in APY lands. Were you there as a physiotherapist, or
No, I was there
what role were you there in?
as a health service manager.
I see. And did you observe the work of allied health professionals, such as physios, while you were there?
Yes, but services were very scant. So I met an occupational therapist, and I heard of a physiotherapist that work as a team. They were employed by the state community services agency, and they provided a fly-in, fly-out service on a very intermittent basis. So access was
So they
extremely
weren't
limited.
living on the lands.
No.
And when they were there, how did they get their clients? Were they referred to them by general practitioners, or how else did they know that a particular person was in need of their services?
So they received. So to my knowledge, the health service did not make referrals to those allied health professionals. Their referrals came from community, from other organisations, for example, who are providing services onto the lands, and so they may be disability-related services or aged care-related services focusing on community settings.
And what about the physical facilities in which the services were provided? Were they already there and available for use, or how did it, or did the allied health professional go to the homes of the people who they were looking after? How did it work?
I think that because of the nature of the services they were providing, that they would often be, for example, undertaking home assessments. So they were looking at, I wouldn't necessarily say that therapeutic services were being provided, they were more at an assessment level. So for the OT, that would be looking at home environments and a person's capacity to operate within that environment, and then making recommendations about how to improve that. For the physiotherapist, it would have been about that person's functional capacity and prescribing exercises and the like to maintain their level of function or improve it. Yeah.
And for the most part, I would assume that the allied health professional had to bring his or her equipment in with them.
Yes, but for that type of service, the equipment needs would have been portable. So as I said, it's more an assessment level of service and not necessarily around interventions. And I would suggest that access to therapeutic equipment and therapeutic facilities was non-existent.
So when the health professional left, the equipment to assist with exercise, for example, went with them.
Yes, that's right. Yeah. So yeah.
Anything arising out of that?
No, thank you, Commissioner.
Well, you've clarified for me the great difficulties that exist in this country in delivering services to rural and remote communities. If I may say so slightly flippantly, I was very interested to see that you were running a matrimonial meeting arrangements as part of the training programs that you're encouraging people to undertake, and I hope they work. We might get more people staying in rural areas if both parties
Are you
committed
referring
to
to
the
a
role.
farmer wants a wife or something like that? Or
But it's been a most interesting expose of just what life is like in those areas, and we have to turn our minds to thinking about what we can do to improve them, and you've certainly made some very helpful suggestions for which we thank you.
Okay, thank you.
The Commission will temporarily adjourn.
Royal Commission's temporarily adjourned.
Yes, Mr. Rosen.
Thank you, Commissioners. Commissioners, our last three witnesses for our hearing here in Darwin are in the witness box. They live and work in aged care in Darwin, and thank you. Ms Morgan, can we start with you, please? And can you confirm for me that your full name is Anna Elise Morgan?
Yes, that's correct.
And Ms Morgan, you are an independent director of the Larrakia Nation Aboriginal Corporation.
That's correct.
You've held that position since May of 2017.
Yes.
And you have a long history in public service generally, but particularly in organisations concerned. Thank you. Ms Morgan, can we start with you, please? And can you confirm for me that your full name is Anna Elise Morgan?
Yes, that's correct.
And Ms Morgan, you are an independent director of the Larrakia Nation Aboriginal Corporation.
That's correct.
You've held that position since May of 2017.
Yes.
And you have a long history in public service generally, but particularly in organisations concerned with Aboriginal affairs.
That's correct.
Turning to you, Ms McCall, there are some biographical details about you in the statement, which I'll come to in a moment at paragraph 10. But your full name is Michelle McCall.
That's correct.
And you're the Aged and Disability Care Program Manager for the Larrakia Nation Aboriginal Corporation.
Yes,
And you've held that position since October 2017.
that's correct.
You're a qualified assistant in nursing.
Mm-hmm.
You also have a Certificate 3 in aged care.
Yes.
Yes. And you have a long history, over 30 years working in aged care. And
That's
the
right.
last 13 of those has been in the Northern Territory.
That's correct.
Finally, Ms Johnson, your full name is Sharai Johnson? Yes. And Sharai is spelled Sharay?
AI.
AI, I'm sorry. It's pronounced Sharai, isn't it? Not Sharai. Thank you. And you're a Larrakia and Gurung woman. And I think you wish to, at this point, extend a welcome to us.
Yes, please.
Please do that.
Thank you. Good afternoon. My name is Sharai Johnson. Thank you for inviting me to do this welcome here today. I am a Larrakia woman and I respectfully acknowledge the past, present, traditional custodians on this land of which we are meeting, the Larrakia people. The Larrakia are the traditional owners of the country around Darwin Harbour, east to the Adelaide River and south to the Finniss River. Larrakia people are also known as Gulamiran or Dungalaba people, after our main totem, the crocodile. We are saltwater people and traditionally our lives are dependent on the coast and seas. As traditional owners, we have a responsibility for looking after everyone that visits or lives on our country. You have come by way of the Larrakia land. You will hear the voice of Larrakia ancestors. When you leave, the Larrakia message will stay with you. I pay respect to elders past, present and emerging. It is my privilege, and on behalf of my elders and the Larrakia people, I welcome you all to our land. On behalf of the Larrakia, welcome.
Thank you very much. We have been blessed both on Monday as we began and this afternoon as we conclude with very generous welcomes from the Larrakia people. We thank you for it and we assure you that the work of the Commission will do its best to ensure the ongoing well-being of your people and Aboriginal and Torres Strait Islander people throughout this nation. Thank you.
Yes. Ms Johnson, you are the Aged Care Coordinator with the Larrakia Nation Aboriginal Corporation.
Yes, I am.
And that's a position you've only come into recently, in
Yes, it
May
is.
of this year?
Yes,
All right. Yeah, you hold a Certificate 3 in Aged and Community Care.
I do.
and you two have a long history, perhaps not as long as Ms McCall's, but a long history of involvement in aged care provision.
That's correct.
Now, there is a little video, at the risk of embarrassing you, which is at tab 147 of the tender bundle, and you do tend somewhat to star in this particular video recording, but I think it usefully introduces you to the Royal Commission. Perhaps if that could now be played, please, at tab 147 of the general tender bundle.
My name is Sheree. Here at Larrakia Nation, I am the Social Group Coordinator. Larrakia Nation has 9 programs in total. The one I'm working for currently, aged care, which is fantastic. There's not enough young people who do it. I'm not too sure why. I think they're scared of the ageing population, have a tendency to move more towards nursing. I feel personally it's really important to implement a lot of activities outside, outdoors for the clients. Some of them, may have mobility issues where they can't access vehicles or don't have the appropriate support to take them places. So try to alternate 1 week in the office where we generally have a really nice morning tea, lunch, play bingo, socialise, and then the alternate week, head to the museum or let's go and have a picnic. When I initially moved to Darwin, obviously I was searching for a career change. So I started applying for jobs. That was in March 2016. And then sure enough, the aged care position became available and I thought, you know what, working with the elders, doesn't matter where you're from, is really important to me. I'm a firm believer in caring for our elders, looking after them. They were once young themselves. A lot of people don't have family. So if I can be that one person to make that difference, then that's what I'm going to do. And I've been here and I'm still here.
Thank you. Apologies for the sound recording there. It was a little bit off key, but I think we got the general message. If I can come back to you, Ms Morgan, for the moment. You have prepared for the purposes of the Royal Commission a witness statement, and it's a statement dated the 9th of July 2019, and it's up on the screen there, wit.0255.0001.0001. As was the case with the statements that we received on Monday from a panel that we heard from, this is a collaborative effort, is it not?
Yes, that's correct.
All right. It's got your name on it, but the work that's gone into it was a joint effort by your colleagues. Have you had an opportunity to read through the statement before giving your evidence today, Ms Morgan?
I have.
And is there anything in that statement as you've signed it that you would like to change?
Nothing.
All right. Before I tender it, I might just ask you, Ms McCall, so far as it reflects the contribution that you made to the preparation of the statement, is there anything in there that you would like to change?
No.
All right. And are you comfortable that the contents are true and correct?
Yes.
And finally, Ms Johnson, so far as your contribution is concerned, is the position the same? All right. There was a fourth contributor who is not with us, Ms Quall, Natalie Quall. Ms Morgan, can you tell us a little bit about Ms Quall and her role at the Larrakia Nation Aboriginal Corporation? Or is it better coming from Ms McCall?
It's better coming from her manager, actually.
Okay, indeed. I'm sorry. Please, Ms.
So Natalie Quall is a Larrakia woman.
Yes.
Who has been with Larrakia Nation Aged Care for almost 11 years now. She has advocated for the clients for that whole time. She has worked across the whole range of areas within aged care, but her passion is cooking. So she actually is the Meals on Wheels coordinator now.
And she's unwell presently.
Yes.
Was unable to join you three today. On that basis, a little bit like we did on Monday, Commissioners, I'd seek to tender the statement of Ms Morgan, the contents of which are agreed to by her colleagues.
Yes, on that basis, the statement of Anna Elise Morgan dated the 9th of July 2019 will become Exhibit 6-34.
Commission pleases. Ms Morgan, can I start by asking you to tell us a little bit about the Larrakia Nation Aboriginal Corporation, and perhaps if we could have on the screen paragraphs 30 and 31, which are on page 6, that may be of assistance to you. I hope you're able to see that screen, or you've got a copy in front of you. So the corporation's been in existence since 1997.
That's correct.
And why was it established?
It was established as an advocacy organisation to represent the interests of the 8 Larrakia families.
Yes.
In particular, to assist in returning land and facilitating land management activities so that people could remain connected to country.
Yes. So we see that the corporation provides a range of services, and we'll talk about a number of those in a moment, one of which is aged care services. I see at paragraph 31 that during the, what's 22 years now since it was established, it's expanded significantly. Is that in terms of employees or in terms of service provision, or both?
Both.
Right.
So in particular, in the last 3 years, our membership has increased quite significantly, but we now are a 600 member strong organisation.
Yes.
In addition to that, our staffing levels have doubled, and that includes Indigenous, non-Indigenous and Larrakia employees.
Yes.
And our program delivery has expanded enormously. So doubling of outreach services from night patrols to day patrols, and looking after people euphemistically known as long grassers, who are people who are sleeping rough, connecting them with services.
Yes.
Youth link-up services, a whole plethora of services, some of which existed already but have now been quite dramatically expanded.
I take it a number of those services were just not previously being provided before the establishment of the corporation. Is that?
Well, that's correct. Larrakia people, as traditional owners of this land, have a very strong sense of needing to look after the welfare of those people on the land, be they, as the welcome says, visitors or residents.
Yes.
And in thinking about the services that Larrakia provides, one could say that it actually goes beyond the remit of simply representing the interests of Larrakia. It's also about caring for the people on Larrakia land.
Yes, and we'll see in a moment that the services that are provided are not just to Larrakia people, they're not just to Aboriginal people, they extend beyond that to others on the land. We'll come to that in a moment. Ms McCall, perhaps if I could just come to you, sorry, Ms Mitchell, if I could come to you presently. The range of services that are provided, those personal services, outreach programs, day and night patrol and so on, do they all fall under your area of responsibility? Perhaps you could just explain to us the internal arrangement within the corporation and what you're responsible for.
No, so what falls under my area is aged care. So it will be in-home care. So it will be home care packages and Commonwealth home support packages, so both high level and lower level. Part of the CHSP, which is Commonwealth home support packages,
yes,
is the ACHCA program, which is Assistance with Care and Housing. So that program is to link long grassers or those people living rough with accommodations so that aged care can come in and provide services to them in their own homes.
Can I just ask you a little bit about that? It's dealt with at paragraph 36 of your statement, the ACHA program. So that's Commonwealth Assistance with Care and Housing for the Aged. It is an area that Commission has a particular interest in. Can you just explain in a practical sense how that program is applied in this area, the Larrakia Nation area?
Okay, so So we have one staff member. We're funding for one staff member to provide services
Yes.
for those. That staff member will be on the road all working week.
Yes.
That would involve identifying long grassers in need of care, also through referrals of word of mouth from other service providers. And then he'll be tasked with ensuring that these people are getting into accommodation, whether it be short-term emergency accommodation, but the view is for a longer-term, more stable accommodation, and also linking them up to other services, not just aged care, but aged care to get them into, get services into the house, but if they have any other, such as renal, hooking them up with renal, finding a health practitioner or a health clinic for them that they haven't been using. So it's intense case management.
Yes.
Initially, till a service provider comes in and provides the service.
Now, I neglected to raise something with you, and I think I should probably do it at this point because it is a matter that's dealt with in the submission. Just by way of background, attached to the statement that the corporation has provided that's now part of the evidence was a very detailed and comprehensive submission that was prepared and provided to the Royal Commission. We don't really have time to go through all of it, but you can rest assured it's all being considered by the Commission staff. There's one area that I wanted to specifically raise with you. The submission is at tab 67 of the general tender bundle. And perhaps if that could be brought up with particular attention focused on paragraph 12 at the bottom of the third page, page 3 of 9, and there are many attachments. You'll see at the bottom there, paragraph 12, which will be highlighted on the screen for you, there's a reference to the M geographical classification system, which the Commission heard a bit of evidence about in Broome. Mm-hmm. That's the modified Monash model. I think I've got that right. Yes, that's you're nodding. Thank you. There's a particular concern about the application of that model that's identified in the submission at paragraph 16 on the following page. I wonder if I could just... Yeah, sorry, it's the next page, page 4, that's right, paragraph 16 being highlighted there. In a practical sense, can you assist us to understand the concerns the corporation has with the application of the model here in Darwin?
Sure. So the application of the model is based on where your office is situated, not where you're providing services. So the issue with Darwin is that it's a large area. So even the satellite city of Palmerston, if you're going from the city into some suburbs of Palmerston, it's a 30-minute drive. But because our office is based in Darwin, we're still classified as urban. 5 minutes out of Palmerston, it's classified as rural, and 5 minutes again is classified as remote. So the issue that we're facing is that's the service provision and the viability of service provision when we're classified as urban is that it can take us an hour round trip to provide half an hour of service.
Thank you. I wanted to ask you about one other service that is identified in the back to the statement. If we can go back to the statement at paragraph 33 on page 7, there's a heading return to country. And the statement says the return to country program assists people to get home. We had a deal of evidence about the importance of returning to country on Monday, earlier in this week. Perhaps I could just ask you, firstly, Ms McCall, and then I'll come to you, Ms Johnson, on this topic, because I know you've got a contribution to make. How does that service work? What service is provided there?
Okay, so Anna, would you like to speak on behalf of Return to Country?
Yes. So one of the big issues in all remote communities is access to services.
Yes.
And for Aboriginal people in remote areas that have to come to Darwin, for example, for medical services or family reasons or whatever, the issue for them is they will simply arrive. There'll be no accommodation support for them. There'll be no referral officers to guide them in where they go and what they do. And so invariably they end up sleeping rough. And so the night patrols, for example, would come in to the areas where people are congregating, and they would basically perform an outreach referral service. So they'd check why people are here. Do they need to be transported to hospital? Do they need doctor's appointments? Is there medication that's required? All those sorts of things, so they can help people to get to where they need to be. And then on a return journey, through arrangements with the Northern Territory Government, they also arrange for people to get home. And one of the things Larrakia is doing at the moment is working on a database that will allow people to advise us when people from remote communities are coming and why they're coming, so that we can link them into services straight away, and then organise for people to get home again.
Yes, thanks very much. Ms Johnson, if I can come to you now and ask you if you can give us an overview of the aged care services that are provided by the corporation, because the corporation, of course, is an approved provider of aged care services under the Aged Care Act. So can you give us a sense of the different sorts of services that you're involved in providing?
So on a daily basis, Larrakia Aged Care provides multiple services, which include transport, Meals on Wheels, personal care, domestic assistance, social support individuals. So that could also include taking clients out on a daily basis, assisting them with hobbies that they may be, participating in, swimming and whatnot, whether or not they have hydrotherapy sessions, doctor's appointments. So there's various services that we provide to support our clients with. Yeah.
And is that under the banner of the CHSP
Yes.
program, like all the services that you've been talking about?
Yeah.
At paragraph 37 of the statement, you give us some statistics about the numbers of clients receiving assistance, and there are 99 clients receiving Commonwealth Home Support Program, and they're giving us a description of the sort of services they're getting, and they're obviously quite varied, the services that are provided as part of CHSP. And then there are 14 clients who are in receipt of home care packages. We've heard a lot of evidence here in Darwin and elsewhere where the Royal Commission's been about delays in people getting home care packages once they've been assessed. Is that part of your experience, the delays, particularly of the level 3 and 4 home care packages?
Yes.
Can you tell us a bit about that, how you experience those delays, particularly how the clients experience those delays?
So, for instance, generally, we should be waiting at approximately 18 months wait period.
Yes. From assessment to the provision of
service. Yes, that's correct. We do have one client who has waited 28 months from the assessment up until receiving the provision of services.
Yes.
Yeah.
We've heard elsewhere that it's not uncommon for someone to wait so long that they will ultimately end up going into residential care because they just can't keep waiting and they might be deteriorating. Is that also your experience here?
That is. I found in my experience that quite a lot of the clients rapidly decline in health.
Yes.
Whilst waiting to receive their provision of services.
Yes. Yeah. I mean, it's not unheard of, is it, for a client to actually pass away whilst awaiting the receipt of services? Is that part of your experience?
Yes.
That must be a very difficult thing for you and others dealing with the clients to have to deal with. I didn't ask you, but is it just you providing the aged care services? Presumably not. You've got a team of people working for you in the provision of aged care services?
Yeah, we have 20 staff members.
Right, okay. And can you give us a bit of a sense of their backgrounds in terms of age and gender?
Okay,
please?
so out of the 20 staff members, we have 13 Indigenous, 12 of which are Larrakia staff members.
Yes.
But we also have different cultures such as Nepalese, African as well working with us.
Yes.
We're bucking the trend at the moment, so we are actually being lucky enough to have, we're attracting young staff members. We're also attracting young male staff members, which is not something that is usually happens, but we've been lucky enough to be able to do that.
Well, I can assure you that on our travels around the country, we've very rarely come across male workers in aged care, let alone young male workers in aged care. So this is an opportunity for the Commission to find out a little bit about what your secret is, I think. How that's been a deliberate strategy, has it?
It has been
to
a
try and
deliberate
attract male workers?
Young and Indigenous was the initial strategy.
Yes.
It so happens to be that we're getting young Larrakia men.
Yes.
So the strategy was to do that, to bring that into force. But we're also selling aged care different. Aged care is quite commonly viewed a certain way.
Yes.
And that, I think, at the point being in Sheree's video, that we're looking for passion. We're selling aged care for helping the elders. We're selling aged care as it's not just all doom and gloom. It can be fun. You're making a difference to the quality of people's lives. You're supporting people to remain in their homes. And I think that's one of the key things that have been able for us to attract and retain our workforce.
Yeah. And just if we can just stick to the male workforce for the moment, one of the services provided is a men's group, is it not? I think which happens to be today. That's Friday's the men's group day. You tell us a bit about the men's group service to the extent that you're able to.
Okay, so the men's group was formed out of need.
Yes.
We had a social support as part of the Commonwealth Home Support Program, and we filled up very, very quickly, and we were getting clients asking us for women's and men's group. So the men's group meet each Friday, and they can do a range of things. So they might be in there painting or wood carving. They might be back on land collecting long bums to cook up. They'll be having picnics in the park. And they look forward to it. The clients look forward to it. They know when we pick them up in the mornings and when we come around to pick them up for the social day, if we're 2 minutes late, we'll get a phone call. So they really look forward to that social interaction and the men's only group.
If I can come back to you, Ms Johnson, if I could, please. We got a bit of a sense of your passion for working in aged care from the video, of course. But do you agree with what Ms McCall says about the positive experience of working in aged care? Has that also been your experience?
Absolutely.
And why is that? What is it that makes it so rewarding?
What makes it so rewarding is that you know that you're having a positive impact on each individual's life, their daily living. And if you can be that one person to make that change on a daily basis, then that's a wonderful outcome, not only for, my personal satisfaction, my professional development, and giving that back to the community, giving that back to the workforce, and also mentoring younger staff members, just the younger generation in general, showing them that aged care it's a great place to be. It is a wonderful place to be. It is so rewarding, and you know what? You just keep going every day.
You spoke about mentoring, Ms McCall. If I can come back to you, is that an important part about your ability to retain staff?
Absolutely.
And why, it's probably obvious, but if you could just expand on why that is and the sort of mentoring arrangements that you have in place.
Okay, so we made the decision to employ people initially for the view to get in younger staff members and Indigenous staff members we made the decision to employ highly qualified and highly experienced staff members, first and foremost. So we have those in place, so we're able to attract the younger staff members, and they're learning the right way. They're being taught and mentored by qualified staff. We've also, on the cultural side of it, we have not only Sheree, but we have also Natalie, who is a coordinator, and also another Larrakia man, who's another care coordinator, who are in a position there now to mentor those Indigenous staff members.
Ms Johnson, I see that one of the training programs you've done is related specifically to dementia care. Firstly, could you tell us what that was? Is that something you did online, or is it something you did locally here?
Okay, so I participated locally for and with Dementia Australia here in Darwin. They provide 3-day courses, brief short courses that staff here in Darwin are readily able to access.
Yes.
So I've been participating in extensive dementia essentials training, which ultimately provides a broad overview of what it is like for an individual living with dementia.
Yes.
Fantastic.
I know that just from talking to you that one of the features of the training has been a simulation exercise.
Yes.
Can you tell the Commissioners about your experience of that and how that's assisted you in the work that you do?
Yes, so the last round of training I participated in was called Enabling Eddie, which ultimately consists of wearing virtual reality goggles. So you place the goggles on, and for me, you have a visual aspect, an overview of what it's like for a person living with dementia. So something as such as these carpets that we're looking at today, in the eyes of a person living with dementia, would be a black sinkhole. The writing on this paper in front of me would be something that constantly fluctuates, so it's very difficult. From my personal experience, that course, which was scheduled to take 4 hours, was something that took me 6 hours because it was physically making me feel sick, having to take the goggles off and put them back on.
Yeah.
So that gave me a great insight, and you know what, that was knowledge and skills I was able to bring back to Larrakia Aged Care, mentor and discuss with my staff. And yeah, it was a great experience.
There's another aspect of dementia care that I wanted to ask you about. It links back to people returning to country. And can you share with the Commissioners your experience of the program that you've described to me when we met the other day of taking Aboriginal people with dementia back on country, and how that program assists them? I hope you know what I'm talking about.
Yeah.
Yes.
So under the service provision of the CHSP program, one of the deliveries we provide is social support individual. And what we've found with clients of ours who have dementia is taking them out of their homes into public places or places that would be fairly familiar to them. And it brings back positive memories of theirs that they wouldn't generally discuss on a daily basis. So reminiscing about things in their past, people that they have met, being in a certain place could remind them of what they were doing at a certain time in their lives. It's been a wonderful experience to watch a lot of our clients show positive signs. So that's because we've had such a positive outcome in doing that. That's something that we're now providing regularly, and it's been great.
Ms McCall, is there anything you'd like to add on that front?
Well, I'd like to add in the written submission, you'll see the case study and the one that Sheree just touched on those. So with that particular client,
We'll bring that up on the screen. So it's in tab 67. I'm sorry to interrupt you. It's on page 8. I think it's case study 1. Is that the one we're talking about? Or maybe I've got that wrong. There's 4 case studies on that page.
No.
It's not that one, I'm sorry. No? Do you have a copy of the submission in front of you? I think you do.
I have. I'm just trying to
Is
find.
it one of those case studies? There's 4 there on that page.
No, that's not the one that I was
Okay,
speaking about. I'm sorry. I must have.
Put that to one side and go back to telling us about it. If you don't
I'm
mind.
terribly sorry.
No, that's all right.
So this client had significant behavioural, complex behaviour issues. When we identified a staff member to go with this client on a social support individual, that client, as Sheree was saying, was then taken to places or to invoke memories, places of significance, importance. And we have seen such a stark improvement in the behavioural, complex behaviours of that client since that has been occurring. That client used to have behaviours on a daily basis. We were just talking this morning, we can't remember the last time that client actually had a complex behaviour issue.
I wanted to ask you about something which appears at paragraph 55 of your statement. And Ms Morgan, this might be a matter for you, I'm not sure, but there's a reference to dignity of risk and the importance that's played there. Is that something you can expand on?
I think that's, I know what it means.
Yes.
But Michelle's the person with the personal experience.
All roads lead to you, Ms McCall. So can you help us there, please?
Okay, so the dignity of risks. So what we also stress is that we're a support service. We take the care out of it. We do care, but we make it very clear that we're support so that that person can remain independent as long as possible. The care that they are provided is the care that they choose to get when they choose to get it. So if they choose to do something that is risky to themselves or choose not to do something that could lead to risk, we will stand by the dignity of risk. So our staff members or us ourselves will speak to that client. We will explain the risks should they choose to follow the path that they were doing.
Yes.
But if they choose to continue down that path, then we stand by dignity of risk. That is their choice to stand by that.
Can you give us an example of the sort of, are you talking about risky behaviour, so smoking, for example, or
Exactly. It could be from smoking to drinking alcohol or to allowing repeat aggressive people into their homes.
Yes.
Even down to a bath mat that is fringed, which is a huge slip risk.
Yes, yes.
But if they want that bath mat there, as long as they are aware that they can trip on it, it can cause injury, they could end up in hospital. If they still choose to have that bath mat there, then that's their choice. That's their dignity.
I meant to ask you before, and I'll do it now. You have a long history in aged care, previously in Queensland. Is that right? Where originally?
Originally in Queensland,
Yes.
last 13 years here.
Here, but only recently working for the Larrakia.
That's correct.
Where were you previously? You don't have to mention the name, but what I'm trying to get a sense of is how the aged care services provided by the corporation compare to your previous experiences in aged care generally.
So I was working for a Commonwealth government
Yes.
as a NT investigations manager, and that was predominantly aged care.
Yes. Resi care primarily, was it?
It turned out to be resi care primarily, but it did cover everything. So it was also home care. So not only did we investigate complaints from either service providers or clients or their family, We could also do our own motion. So if we thought there was a systemic issue or were identifying a systemic issue, we would investigate that. But we also monitored compliance with the Aged Care Act, service providers or approved providers, compliance with the Act.
And so you weren't so much involved in the provision of aged care, but rather the oversight of others doing it. With that sort of in mind, how does the aged care work that you're now involved in at the corporation, how does it compare to other experiences that you've seen in aged care?
It's significantly different.
Yeah, in what way?
So the choice. So it's consumer-directed care, and it's something that we've taken a stand. Larrakia Nation has taken a stand with. It's the care. This is the client's care, the way a client wants it. So the older model was basically you're assigned to a approved provider. You didn't have a choice on whose approved provider was going to be. And also we're very much for the support. It's about support in the home to maintain that independence, not to just ship them off into a residential facility once their needs are too high. We will do everything we can to keep them in their homes for as safe and as long as possible, as long as they choose to be there.
Is another aspect of that consumer-directed approach something that you deal with at paragraph 60 of the statement? If I could ask you about this is under the heading challenges, the awareness of entitlement to support. Is that a problem? We've heard a bit about this week. There's people just not being aware of what they're actually entitled to.
Absolutely.
Could you expand on that here?
So in that paragraph again, you'll see that we've recently had a significant increase of 160% in service provision.
Yes.
Majority of that was word of mouth. We would give assistance. Obviously, the referrals come through the My Aged Care portal, but for people to know about that in the first place. So it is a challenge of people knowing that they are entitled to aged care services, that services are available, and how to access those services. So they're the three main hurdles.
Yes.
We've got clients who had no idea. We've got clients now in their 90s that were struggling at home, and the family were providing as much support as possible, but they weren't aware that they were entitled to services.
And so what's the answer to that? How can people be made more aware, or what do you do to spread that awareness?
Okay, so we advocate for aged care constantly, or Larrakia Aged Care constantly. We advocate also with our ACHCA.
Yes.
But also we've got the other services like day and night patrol. They might do a referral to us.
Yes.
But also letting people know. We've got the host now. There are brochures that are up there in the host. But just education, people needing to be aware, and I think it goes down to other service providers as well, such as clinics and that, knowing that the services are available.
Yes, we heard just on that point on Monday from the Danila-Dorba service that you no doubt very familiar with, and also the Congress service down in Alice Springs, and they were all making the point really that there needed to be more information sharing between primary health networks and aged care services. I see you're nodding. Is that something that resonates with you? And has it been a problem in a practical sense, that lack of linkages between primary health and the aged care sector?
I think traditionally it was.
Yes.
I can't say that I've experienced that with in this role with Larrakia Nation. We work quite significantly with Danila-Dorba.
Yes.
Congress is obviously central, but we work significantly with Danila-Dorba from case management with our clients.
Yes.
So they're fully involved.
Ms. Johnson, can you add anything there from your perspective? Do you think more needs to be done to provide those linkages, or do you think it works pretty well in your
I think it
in your
works
experience?
pretty well
Yes.
with what we've been doing, yeah.
Now, you told us earlier about the positive aspects of working in aged care very clearly. Can you tell the Commission, are there any, I'm sure there are hard parts about your job too. Can you tell the Commission what perhaps is the hardest part about working in aged care in your experience?
So the hardest part that I've ever had to face working for Larrakia Aged Care would be that I had worked tirelessly and effortlessly with one client in particular and built an absolute great rapport with her. And for medical reasons, she had to go to the hospital, in which she never returned home. So as part of Larrakia Aged Care providing the social support groups, the mixed group on Tuesday, the ladies group on Wednesday and the men's group on Friday, and having participants who do have dementia that were looking for this client and wondering why she wasn't there, why she, hadn't been showing up. So for a person with dementia, that they have such rapid memory loss, so it's something that we could explain to them, but then no more than 30 seconds later, they would forget. So that was a very emotional, and it still is very emotional, because working in the aged care sector, it's not something that's just going to happen one-off. It's something that is consistent. It is something that is continual, and it is a part of our life cycle. So you keep going.
Now, finally, if I could ask you to focus on it's the second last page of the statement. There's a heading, Aged Care Services Challenges, and obviously I'd like you to focus not only on challenges but opportunities that might present themselves to meet those challenges. The first one that's there, not surprisingly, is funding, and the point that you refer to there is subsidising people from other funding where there's decline. Ms McCall, are you able to expand on what the point that's being made there at paragraph 57?
So the point that's being made there is that, as you're aware, the HCP, the home care packages, are individually funded.
Yes.
The issue is the length of the waits for the HCP. So those clients are having to utilise CHSP, so the Commonwealth Home Support Programs. That's block funded with a certain amount of units. Not only are the units not covering the unit cost to the service provider, there is insufficient unit numbers. So we're knocking back people, 30 people a month. We're saying, I'm sorry, we can't provide you services because there's no room for negotiation in increasing the service unit numbers,
yes.
Which will be able to provide more services to more clients, or more services to existing clients as well. But also the viability of aged care in the long term. Aged care is all about the client. However, we have to be realistic with the funding. It has to be viable in the future. We would have, if our unit prices aren't able to be negotiated and an additional funding coming in, then we're going to have 112 clients who wouldn't be able to be sustained in the future.
Can I just clarify that if I can?
Sure.
Try and understand it. Is there an annual process of funding being provided under CHSP? Is that how it works?
So it was a 2-year cycle.
Yes.
That 2-year cycle, the contractor's provided, saying that it's going to roll over. Another one's going to roll over again for an additional 2 years this month. But that's it. We have got, other than the small increment of 2.5% in costings, there is no room for negotiation. So you sign that contract to continue to provide services, but there's no room to negotiate the unit numbers or the unit costs. whereas new providers, so if you're walking in as a new provider, you're able to negotiate.
Yes. So you're calling for a bit more flexibility in the contractual arrangements.
Oh, absolutely. Yep. So
understand.
that people aren't missing out on services.
Can I ask you about the paragraph 62? There's a reference there to client contributions, and I don't know if that's you, Ms. McCall, again. What's the issue there?
So there's an issue with both CHSP and HCP. So HCP is individually funded. The client gets assessed, and we will get a quarterly review saying that this client is able to pay this amount of money daily for the service provision. On the website, it says that you may be asked for a client contribution. Well, in fact, that money will be taken out of the money paid to the department, paid to the service provider.
Yes.
For their care.
Even if you don't get the money from the
That's
client.
correct.
And I assume the source of money from the client is a government pension or something of that kind.
That's correct.
And the point you're making there is the end result is the client doesn't get the service.
That's right.
Yes.
That's right. It limits the amount of service that
Yes,
they can provide.
Yes.
Yeah.
And the final point there is under the heading carers, paragraph 63. I can just understand that if I can. This is family members as carers, and there's a particular dilemma that arises here. You can just explain it, please.
So what our experience is in the Northern Territory is that people, family members decide to become carers of the elderly.
Yes.
They only have to be living there to be able to go in and say, I'm caring for this person, to get the funds, to get payment for a carer,
Yes.
carer's payment. Those carers have nil experience, very, very little experience in providing the role of providing care to that elderly client. So we're seeing quite a significant amount of abuse, whether it be neglect, financial, whole range.
Yes.
And because the carers are not experienced in providing care to the client, they have no idea, and it's the service providers or the approved providers that really need to pick up that slack to ensure that that person is getting the care that they are required.
Yeah. Ms. Johnson, is there anything you wanted to add on that point, or any of the other matters that have been raised?
That's
No.
everything. Michelle captured everything.
All right, terrific. Commissioners, there's the questions that I have for the panel members.
Yes, thank you, Mr. Rosen. Am I right in thinking that a lot of the clients that you look after are not Larrakia people?
59% are Indigenous, and then we have a whole range of other clients.
And does your government funding take account of that fact?
No.
If you weren't looking after these people in the long grass, I assume nobody else would be.
That's correct.
If you're expending your resources to do that, and the funding that you're using to do it is not taking account of the fact that they're not local people.
That's correct.
Anything arising?
There's nothing arising, thank you, sir.
Well, it's been a fascinating end to our Darwin sittings. Thank you so much for explaining to us how services are provided here and the difficulties you encounter and the highlights and the good bits that you experience in providing those services. We're very grateful to you. Thank you very much, and we'll certainly be taking your submission and what you've told us today into account when we come to make our recommendations to government. Thank you very much. please feel free to go back into the body of the hearing room. Mr. Rosen's going to deliver a short concluding submission, and then we'll be adjourning. Yes, Mr. Rose.
Thank you, Commissioners. One small housekeeping matter, and then I'll make some closing remarks. It's merely just to place on record that the tender bundle which Mr. Gray QC tendered at the outset, which is Exhibit 6.1, has grown during the course of the week and now has 147 tabs. And there is an index that is, of course, available to anyone who wishes to know what those tabs are. That will no doubt continue to grow during the Cairns hearing, and I'll update everyone in relation to that. Commissioners, as opened by Mr. Gray QC on Monday of this week, the themes of the Royal Commission this week and next week are quality of care, including its personal and clinical dimensions, quality of life for people receiving aged care, and access to aged care for rural, regional and remote Australians, including Aboriginal and Torres Strait Islander people living in the Northern Territory. The Royal Commission is still to hear evidence on some of these themes next week in Cairns. We will provide a detailed closing at the end of the Cairns leg of this hearing. Now we'll provide a short closing focusing on the issues particular to the Northern Territory. Before I commence that, I'll repeat what has been said a number of times in opening and closing addresses that Council assisting have made, and that is the importance of submissions for the Royal Commission. We place great emphasis on submissions that have been received from members of the public, and we encourage all members of the public that wish to be involved in the proceedings of the Commission to provide us with submissions about their experiences. As I think Commissioner Tracy, you've said on previous occasions, both good and bad of the aged care system. They are invaluable to us in our work. On Monday of this week and earlier today, we've heard some powerful evidence about the stark challenges faced by Aboriginal and Torres Strait Islander older people living in the Northern Territory. The challenges include poverty, food insecurity, service accessibility, lack of culturally safe and secure services, and distance. We've heard about the profound impact on quality of life of being away from family and being away from country. We are very grateful to have heard from Ms Mildred Numadurdi, an Aboriginal elder and traditional owner from Numbulwar, who had to travel around 800 kilometres from her home because of her care needs and is now a resident in a Palmerston residential aged care facility. Ms Numadurdi told us that she was crying for 4 weeks following her admission after a hospital stay. She missed her family, she missed ceremony, and she missed eating the food that she ate at home. We heard about the personal impact of her connection to country and her role as an elder in her community. Memorably, she said, and I quote, "My heart is crying because I'm far away from my family. Yes, because if I pass away here, I've got my spirit, my culture, my ceremony way back home, at home, and my family, they don't want that way because we've got everything there in the home, and that's my motherland, Numbulwar. Yes, I'm the eldest out of my family, and so they worry." Moving away from your local community is, of course, not only an issue for Aboriginal Territorians, with Ms Lovegrove earlier today describing the challenges her father faced having to relocate to Darwin as his care needs changed. Aboriginal elders being away from country can have profound consequences for their family and community and Australia as a whole because of the cultural knowledge that they hold. Commissioners will recall on Monday Ms Sarah Brown, the Chief Executive of that remarkable organisation Purple House, who said to us, and I quote, "We've got senior people with the cultural knowledge of particular bits of land of Australia that has been passed on to them, and they're away from their country. If they don't get an opportunity to return to teach their kids and their grandkids their cultural heritage, it's lost, not only for those families, but the whole community and the whole of Australia loses that knowledge." the Royal Commission has heard about the high clinical and health needs of Aboriginal and Torres Strait Islander people, building on the evidence that it heard in the Broome and Perth hearings. We've heard that older Aboriginal and Torres Strait Islander people in the Northern Territory, as across the rest of Australia, have high rates of diabetes, renal failure, and other multiple complex health problems. Yesterday, Commissioners, we heard from diabetes expert Professor Sussman. He told us that the number of Aboriginal women with gestational diabetes is 10 times that of non-Aboriginal and Torres Strait Islander community. He told us that death rates from diabetes are much higher among our Aboriginal and Torres Strait Islander citizens when compared to the rest of the community. He said that these and other similar figures are what he described as a shocking reflection on us as a community. The conditions are, of course, compounded by poor quality of life, poverty and remoteness. We've heard that these health and clinical needs are often not being met, either in community care or residential settings. You heard a panel comprising representatives from Central Australian Aboriginal Congress and Danila Dilba here in Darwin on Monday, and they told us that care needs to be made culturally safe and that this can be achieved through cultural safety training, the use of interpreters and cultural workers, and a workforce that includes people who speak relevant languages. Dr. Giles of Danila Dilba told us of what she described as the shameful inequity that results from an Aboriginal language speaker not having free access to the Aboriginal interpreter service, whereas a care worker speaking any other language has free access to the National Translation and Interpreting Service. In relation to community aged care, we heard about the centrality of basic necessities of living to support people being able to live on country. Ms Kim McRae, team leader of NPY Women's Council, explained the impact of poverty on care needs, noting that the biggest need in community aged care was for nutritious food. She said most people are dependent on Centrelink benefits. There's an obligation to share and support your family, and sometimes the end result of all those things can mean that old people aren't getting enough to eat because they're making sure their grandkids are eating before they're looking after themselves. So making sure that people get access to the meals program, she told us, that they're getting regular nutritious food, can make a huge difference to someone's life. Ms McRae also noted that access to laundry facilities was very important to maintain health, particularly when older people were experiencing incontinence. She said being able to access laundry services, because most people don't have a washing machine in their house, so being able to wash bedding, blankets, clothing, particularly if incontinence is an issue, is really important in terms of maintaining people's health. These examples illustrate the interconnection between quality of life, personal care and clinical needs, themes which we will return to in the Cairns hearing. The witnesses also expressed concerns with access to and the quality of clinical care provided in community setting. Employees of the Larrakia Nation Aboriginal Corporation just given evidence minutes ago about the average wait time in Darwin for a home care package being over 18 months. And Ms Johnson, you'll recall, gave evidence about the difficulties faced by people waiting very long periods of time, upwards of 2 years, she told us in one example, waiting for home care packages. Ms Archie of Congress noted that people with high clinical needs are waiting long periods before receiving level 3 and 4 services that they're eligible for. And you heard similar evidence just now from Ms Johnson. Ms Mackay of the Top End Health Services, the Northern Territory Government, talked about the flow-on impact of waiting lists, particularly for clients needing a level 4 home care package. She noted that the health of these highly complex clients will continue to deteriorate, and hence they'll be more likely to need residential care, or if residential care is not available, they'll need to go to hospital. Both of these options take the clients off country prematurely. Ms Archie and Dr Boffa noted the high clinical needs of people on level 4 home packages, and they called for nurses providing that care to be part of a primary health organisation so they can benefit from the clinical governance and support of a professional team. Ms Mackay agreed this was a concept that was worth exploring. Dr Boffa, you'll recall, lamented a decline in community nursing as a result of the nationalisation of aged care and jurisdictional tensions around responsibility for nursing, noting that it's well established that home visits from nurses to older people with multiple chronic diseases prevent hospitalisations. Monday afternoon's panel also called for greater transparency and information sharing with primary health providers about community aged care eligibility and services. And Ms Archie talked about discovering that a very complex patient had already been assessed as eligible for a home care package, but nobody knew, and the client was not receiving the services they were entitled to and needed. The client and their family had not themselves understood what they were eligible for. Commissioners, we also heard that clinical and personal care needs are not being met in the residential aged care setting in the Northern Territory, and residents' quality of life is suffering. Dr Giles of Danila Dilba talked about challenges in the integration of care for residential aged care recipients, such as access to specialist services in the health system. She gave the example of a client not being able to access assessment from an ophthalmologist for a possibly preventable cause of diminishing vision. First, the client needed an optometrist appointment, which itself was too costly to attend. Dr Boffa of Congress referred to the need for sufficient numbers of nurses in residential aged care to make the care clinically safe, particularly in relation to medications. He said if you don't have enough registered nurses, the system can be unsafe. He also queried whether there's a degree of professional isolation when there are only a handful of registered nurses in a facility, noting that in workplaces where there are a lot of health professionals, they support each other. Dr Boffa also called for salaried GPs in residential aged care that could do more than just provide Medicare rebatable services. They could help the nursing home deal with other issues, he said, such as quality and improvement. And they could support nursing staff in providing good quality medical care. Ms Archie and Dr Boffa questioned at what population level smaller communities should have access to an aged care facility, noting that whilst Mudajulu, which is a community of 500 Aboriginal people, has a residential aged care facility, Numbulwar, which has a larger population of 750, did not. Dr Boffa noted there are large remote communities in the top end that don't have residential aged care facilities, and he called for planning for aged care facilities based on population levels similar to that in the healthcare context. We heard about what is needed to address care needs not being met, including self-determination, resolving workforce issues, allowing for flexible funding and increasing access to aged care services. All witnesses emphasised the importance of self-determination in healthcare. Dr Boffa noted that Aboriginal community-controlled health organisations protect cultural security, particularly in the context of a history of racism, including in healthcare. Ms Archie provided the example of the Institute of Urban Indigenous Health in Brisbane, whom we heard from in the Perth hearing, providing a whole range of aged care services, including residential care. And in this regard, Commissioners, you'll record the evidence of Mr Moore during the Perth hearing about that experience. Many of the witnesses talked about the staffing and workforce challenges in the Northern Territory. Ms Brown, Ms McRae, Ms Archie, Dr Boffa, Ms Havnan and Dr Giles all talked about the importance of having cross-cultural workers, increasing the Aboriginal and Torres Strait Islander workforce and improving non-Aboriginal and Torres Strait Islander people's knowledge of culture and working in appropriate ways. Ms Brown told us how the Purple House organisation works Malparara way, which is, she told us, non-Aboriginal staff working with local Aboriginal people who have the expertise in language and culture. She spoke of the flexibility of their approach, developing job specifications around people and people's strength and what they want to do. Dr Giles, Dr Boffa and Ms Archie discussed the need for better use of interpreters, cultural workers and mandated cross-cultural safety training in aged care facilities. Importantly, Dr Boffa challenged the Royal Commission not to be defeatist. We challenged all of us not to be defeatists. He said that it's a myth, in his view, that it's impossible to recruit health workers to work in remote locations. He said if the necessary accommodation and other infrastructure are provided, it is possible to attract and retain staff even in the most remote locations. And Commissioners, you couldn't do better than what we heard from Ms Johnson about the attractions of working in aged care, which she so eloquently described to us. The Royal Commission heard about the impact suitable funding can have, and particularly for the need for flexible funding models in aged health and community care services. Ms Brown of Purple House talked about the game-changing impact of obtaining a Medicare item number for community-delivered dialysis programs, removing difficulties with cross-border work, jurisdictional challenges, and it offered certainty of funding, providing sustainability. Ms McRae explained the need for funding for people to return to community, even for visits, when they're in residential aged care. Dr Boffa noted the need for appropriate funding of nurses in residential aged care. He called for a funding model that allocated a loading for cultural safety in employing Aboriginal staff and in providing training. And he gave us the example of the Northern Territory General Practice Training Organisation, which sees a loading added so that there are additional resources to employ Aboriginal workers to ensure cultural safety. Together with Ms Archie, he called for greater funding of primary healthcare services for nurses providing level 3 and level 4 home care services so that consistent care could be provided. Ms Mackay queried the relevance of funding premised on consumer-directed care in community care when there are thin or no markets, noting the benefits of block funding and pool funding in providing certainty to service providers in smaller communities. You heard also just now from Ms McCall about the challenges in relation to funding of the Commonwealth Health Support Program, the CHSP, I'm sorry. Lastly, the Commission heard that equity of access to aged care services is fundamental. Ms Havnan, in discussing top-end communities with relatively larger populations, noted the inequity of Aboriginal people's needs not being met. And we quote her evidence here at some length because it captures the frustration of a long-fought battle and the shared views of the panel on Monday. She told us, "I cannot believe that you would find similar-sized towns anywhere else in this country that would not have a residential aged care service. It's simply shocking," she said, "that a town like Nullumbai for years have been told and promised, yes, you'll get an aged care facility, and I can remember consultations going back as far as 2007, we still don't have an aged care service there." The point I really want to emphasise, she told us, is that Aboriginal people have by far the most complex health conditions, complex level of needs, and who actually receive the least level of service, and these are things that are not new. We've talked about it for decades, as Donna and Dr Boffa have said. She said, "You know, we've done a lot of the research. I simply do not understand how we can still face such inequity." And I get it that, you know, there are competing economic and other sorts of priorities, but it's like, when the hell do Aboriginal people's needs get met? Access to aged care for Aboriginal and Torres Strait Islander communities and remote populations more broadly is one dimension of the issue of access to aged care services for people outside the mainstream. The evidence relating to issues influencing the quality of care received by older Aboriginal and Torres Strait Islander people in the Northern Territory shows that the responsibility for improvement does not rest solely with the aged care sector. The critical influence of state and territory health services is particularly important in this regard. The Royal Commission will consider these themes of service interfaces and access for groups with special needs at hearings later this year. Lastly, Commissioners, we wish to close with what Ms Mildred Numamadiri's simple and dignified request. If I can quote from her again, she said, "Can I ask for aged care in a remote community, please? We don't have aged care closer in our community. I'm asking to build aged care in our community." Commissioners, by way of final remarks at this point, can I indicate that Council Assisting consider that it's appropriate, as envisaged at the opening on Monday, for directions to be made at this point. I understand that they may already have been made in what's now become the usual form of directions for written submissions in respect of the case studies.
Those directions have been made and will be, if they're not already, on the Commission website.
And finally, I only need to just conclude, Commissioners, by noting that the Commission will be resuming in Cairns on Monday the 15th of July 2019 at the Cairns Convention Centre.
What you haven't told us is what time we're starting.
I'm very wary of doing that after the experience of the other day, Commissioner. I would assume 10 o'clock.
All right, I've just got them from behind you.
Yeah, that's where all the instructions are coming from. Thank you,
The Commission extends its sincere thanks to Council, instructing solicitors, support staff, technical staff, administrative staff who've made all this possible. It's been very long, intense week here in Darwin. We've learned a lot. We've crammed a lot into a relatively short amount of time, and that's only possible as a result of the hard work of all of the staff who sit before us, and we thank you. Commission will adjourn until the 15th of July in Cairns at 10 a.m.
All stand. The Royal Commission is now adjourned to the 15th of July at 10 a.m.